Okay, so I hope I'm live now. So can we get started? Yes. Okay, so I hope I'm live now. We'll get started. Is there any issues with the audio or video? Please let me know. Okay, so I hope everything is fine. We'll start now. Okay, so I'm starting the discussion with the MCQ questions which I had sent you yesterday. So you can see this is the list which this is the list of questions which I had to given yesterday. So just yes. So yes. So just we will start the discussion now with the MCQs, okay, which I have given to you yesterday in the evening. I hope some of you have, or most of you have gone through that. Okay, fine. So let us get started. This would be the first question. Yes, this would be the first question regarding the, yes. I think the videos are getting added. I hope all of you are online. Okay, anyway, I'll get started. So this was the MCQ question related to the discussion of respiratory disorders in medicine. So look at the first one. A patient during evaluation had decreased vital capacity and decreased total lung volume. What is the most probable diagnosis among the following? Okay, so if you see, I had given few conditions. The basis of this question is to differentiate between the types of lung disorders. Can you see? Bronchiectasis, interstitial lung disease, cystic fibrosis, and asthma. There is nothing specifically given as feature of any of these disorders, but based on the lung function testing, you have to tell me the answer. Yes, decreased vital capacity and decreased total lung volume. So, which type of lung disorder do you get this? Okay, you get this in case of restrictive lung disease. Correct. You get this in case of restrictive lung disease. Okay, because in obstructive lung disease, the total lung volume will be increased. That is what I have told you. Okay, right. So here it is decreased lung volume. So it is suggested of a restrictive lung disease. So which among the following four things are restrictive lung disorders? Okay, answer is going to be this one. What is it? Interstitial lung disease. This is a typical example of restrictive lung disease. If you see bronchiectasis, cystic fibrosis, asthma, all coming under which category? They are coming under obstructive lung disease category. Okay, so that will not be the answer. Okay, so even you can just eliminate the other options, thinking that all of them belong to one group. Interstitial lung disease belongs to another group. Like that, you can easily differentiate between the two. Okay, fine. Then, in an asthmatic patient, second question, correct. In an asthmatic patient, which of the following pulmonary function would show the greatest improvement on inhaling a bronchodilator? Okay, so asthmatic patient is what? Asthmatic patient means type of what disease? It's a obstructive lung disease, correct? And I told you a characteristic feature of obstructive lung disease in asthma will be reversibility. Okay, reversibility. Asthma is a reversible condition. I told you another obstructive lung disease, COPD, is an irreversible condition. So how do we define reversibility? By giving a bronchodilator. Okay, by giving a bronchodilator. So once you give the bronchodilator, what will happen? Which parameter will improve? Okay, which parameter will improve? I told you this very clearly. It is going to be FEV1, correct? FEV1 will improve. I told you this. How much it will improve? More than or equal to 12%. More than or equal to 12%. Okay. After giving a bronchodilator, FEV1 level will increase to more than 12%. Are you able to follow this, right? So the answer is going to be option D. Very correct. Then, which one of the following distinguishes ARDS from cardiogenic pulmonary edema? This was the last topic which we discussed yesterday, acute respiratory distress syndrome. I told you ARDS is a non-cardiogenic pulmonary edema. That's what I told you. It's a non-cardiogenic pulmonary edema. And I had given something called as the Berlin's criteria. I hope you can remember that. There were 4 points in the Berlin's criteria. The last one was something related to the specific differences between cardiogenic and non-cardiogenic pulmonary edema. What was the last one? It was related to pulmonary capillary wedge pressure. Okay, here I have given in the form of pulmonary arterial pressure. That is also something equivalent only. What did I tell you? Answer is going to be normal pulmonary arterial pressure. Okay, normal pulmonary arterial pressure. What will happen? In ARDS, the pressure will be normal. I told you that it would be less than 18 millimeters of mercury. Whereas in cardiogenic pulmonary edema, the pressure would be increased. The pressure would be increased more than 18 millimeters of mercury. If you can recollect that, that was the last topic which I had discussed yesterday. Okay, right. Then moving on to the question number 4, you have a 28-year-old female who has diarrhea, confusion, high-grade fever with bilateral consolidation on an X-ray. What is the probable organism? Okay, I told you whenever the question is given like fever with consolidation, you have to think in terms of pneumonia, correct? You have to think in terms of pneumonia. Now, all the options given in the question, except of course Neisseria meningitis, Legionella, Streptococcus pneumoniae, H. influenza, all can be associated with pneumonia. Okay, Legionella, Streptococcus pneumoniae, H. influenza, all can be associated with pneumonia. But the question is, what specific organism? Okay, here the clues are something like this. What is that? Diarrhea and confusion. These are some additional findings. Usually, for a patient with pneumonia, you expect fever, cough, breathing difficulty like that, and consolidation on an exit. That is fine. But here, some additional findings are given in the form of diarrhea and confusion. So, what this could be? This is going to be something like an atypical manifestation, which is associated with which organism? Yes, I told you that it is Legionella. It is Legionella. Do you remember? I told you about some specific points of each of these particular conditions, and I told in Legionella you have exposure to contaminated ACs, exposure to contaminated AC. You can have gastrointestinal manifestations like diarrhea, neurological manifestations like confusion, and also if you evaluate the patient, what you will get? You will get hyponatremia. You remember that you get hyponatremia. Okay, right. See, these are the clues which will tell you that probably the patient is having Legionella infection. This is one such question. Based on this, one of the questions had come in the recent January exam also. I had mentioned that during the discussion also. Okay, right. So that will be for question number 4. Option A is the answer. Okay, then a patient develops fracture of the shaft of the femur. On day 3, he develops respiratory distress and decreased SpO2 and fatigue. What is the probable diagnosis? Any comments? Anybody? What is the probable diagnosis for this? Shaft of the femur fracture. And day 3, he develops respiratory distress and decreased SpO2 and all. Yes. Any comments? Yes. Anybody? Here, the answer is going to be fat embolism. Some of you were asking the question when I was discussing about pulmonary embolism, how to distinguish whether it's a fat embolism or pulmonary embolism and all. I have told specifically at the time that pulmonary embolism will take little longer time for the manifestation after the event, whereas fat embolism will develop within 48 to 72 hours. Do you remember that? This is a very typical description of that. What is that? Fat embolism usually occurs. Okay, I will write the point here and I will share with you this annotated one, that is the writings after the, maybe the break time I will share it with you. I'll share with the coordinators, they will share it with you. Fat embolism usually occurs within 72 hours. Very important. It usually occurs within 72 hours of the fracture, or I will write skeletal trauma. Within 72 hours of the skeletal trauma. That skeletal trauma, as given in the question, would be in the form of something like fracture. Okay, that is what. It can be something like a road traffic accident where the patient would have suffered trauma to the limbs and all. It usually occurs within 72 hours. Whereas if you look at pulmonary thromboembolism, usually it occurs around 5 to 7 days after trauma. It is 5 to 7 days after the injury, especially post-operative ward and all. That is where you usually get it. Okay, that is one thing. And some of the important clues. Okay, some of the important clues of fat embolism. Some of the important clinical clues of fat embolism would be: one is hypoxia, because that fat can block the pulmonary circulation and it can cause hypoxia. Then it can cause mental status changes. Very important, mental status changes. That is, the patient will have confusion, all those things due to neurological involvement. And third important is small bleeding spots, petechiae in the skin can also be noted. These are the characteristic manifestations of fat embolism, which you should be knowing about. Some of you had a confusion yesterday whether it's fat embolism, pulmonary embolism, and also that is why I wanted you to know about this particular question. Okay, I see that many of you are able to answer this. It's very good, and it's a very important topic also. How to differentiate between fat embolism and pulmonary thromboembolism. Correct? Okay. Then, question number 6. Mesothelioma is most commonly associated with. Mesothelioma is most commonly associated with asbestosis, silicosis, anthracosis, Kohlberg, and pneumoconius. I had mentioned in one of the pneumoconiosis, mesothelioma is a specific manifestation. What is that? Yes, it is asbestosis. In fact, I mentioned it very clearly that whenever you have a patient with mesothelioma, you should always get a history of asbestosis. Sometimes in the past, he would have been exposed to the asbestos fibers. That is what you should remember. Okay, very correct. Most of you got this correct. Answer is asbestosis. Okay, then treatment of choice in a patient of acute pulmonary embolism with right ventricular hypokinesia and compromised cardiac output. What does it tell you? This is a patient with pulmonary embolism. Okay, all right. And I told you, in a patient with pulmonary embolism, we should try to differentiate whether the patient is hemodynamically stable or hemodynamically unstable patient. Okay, you see in this particular question, it is very clearly mentioned. The patient is having right ventricular hypokinesia and compromised cardiac output. Means he's a stable patient or unstable patient. Very, very clear that he's a unstable, hemodynamically unstable patient. Correct? He's a hemodynamically unstable patient. And I told you for all hemodynamically unstable patient, the initial treatment should be in the form of thrombolytic treatment. So the option A will be the answer. Say low molecular weight heparin and all, you will administer only if it's a hemodynamically stable patient. Okay, right? I have told you this. And the IVC filter, I told you, hemodynamically stable patient with a contraindication for anticoagulation, we can go for it. But this is hemodynamically unstable, and so the best answer should be thrombolytic agent. Are you able to follow this, right? Okay, so that will be the answer. 7 answer is A. Okay, moving on to the 9 and 10 question, which are all clinical scenario questions. Okay, a 30-year-old man with the complaints of 2 days of fever, malaise, cough, and greenish sputum production. Okay, fever, cough, and sputum production. This itself tells you probably he's having some sort of lung infection, correct? Fever, cough, and sputum production. He has no significant past history. See, this is only 2-day history. 2-day history. 2-day history means it's an acute infection. Okay, it's an acute infection. Okay, right. He is alert with a temperature of 39, respiratory rate of 28, blood pressure of 110/70 millimeters of mercury, heart rate is little increase 105. SpO2 in the room is normal. That's okay. WBC count is 15,000 means WBC count is increased. Okay, there is leukocytosis. Chest X-ray shows consolidation in the right lower lobe. Now you are convinced that this patient is only having pneumonia. What is that? Lobar consolidation. Correct? It is a pneumonia with lobar consolidation. Question is, which of the following is the most appropriate antibiotic treatment for this particular patient? Now, whenever you manage a patient with pneumonia, I told you, you will follow a criteria called Curve 65 criteria. Correct? It is called Curve 65 criteria. And based on that only, we decide our management. Now, first you do the Curve 65 scoring in this patient, first of all. What is that? C for confusion. Is he having any confusion? No confusion. So for that, I will not give any score 0. U for urea. I told you urea should be more than 20 milligrams per deciliter. Was mentioned in this question, not at all. So again, I'll give a score of 0. Respiratory rate more than 30 per minute. He will give a score of 1. What is the respiratory rate here? It is 28 per minute. So again, give a score of 0. Then B for blood pressure. What is the blood pressure? Where you give a score of 1. Blood pressure of less than 90/60. Okay, less than 90/60. So what is given here? 110/70. That is again in the normal range. So again 0. And 65 refers to age more than 65. What is the age of the patient? The age is 30-year-old male. So again, it is not more than 65, so 0. So curve 65 score in this particular patient is going to be 0. Okay, the curve 65 score in this patient is going to be 0. If it is 0 score, it means it's a mild form of pneumonia. And mild form of pneumonia, you will treat the patient as outpatient with oral antibiotics. Correct? Outpatient with oral antibiotics. I told you, typically we give what type of oral antibiotics. I told you penicillin group like amoxicillin or amoxicillin clavulanic acid should be given. Unfortunately, that is not given the option. So which other antibiotic you will choose? Answer is going to be, I told you, what are the alternatives? Like azithromycin can be given. I told you doxycycline can be given. Which is the answer which is given in the question? It is azithromycin. Very, very simple. Okay, azithromycin. That will be the answer for the question. Okay. If you see, fluconazole is an antifungal agent, which we are not going to use it. Ceftriaxone and piperacillin tazobactam are IV antibiotics, which are not required for a patient who's being managed as an outpatient, right? So that is why the answer for this question is going to be azithromycin. I hope all of you are able to understand how we were discussing this particular question. First, we did curve 65 scoring, and based on that, we decided what could be the management. Clear? Okay, this is a typical example of how do you apply the curve 65 score in a clinical setting. Right, that will be for question number 9. Moving on to question number 10. A 60-year-old male, known hypertensive patient, is being evaluated for 1 hour history of chest pain and dyspnea. The patient has been hospitalized 1 week ago for colectomy. Okay, so this is a patient who has been hospitalized for 1 week in view of colon cancer. He underwent colon colectomy. Okay, removal of the colon. Okay, right. Yes. On examination, he is afebrile. Blood pressure is 110/60 millimeters of mercury. The pulse rate is 120 per minute. Respiratory rate is 24 per minute. Oxygen saturation is 88 in room air, which improves to 97% with 4 liters of oxygen. So definitely he's having hypoxia. Right? This is one of the important things which is given. He's hypoxia. He's having chest pain as well as breathing difficulty. Breath sounds are normal. Chest X-ray is normal. Everything looks to be okay. Which of the following tests should be done for a definitive diagnosis? Now, what is your clinical diagnosis in this case? First of all, what is your clinical diagnosis in this case? He is a patient who has been hospitalized for 1 week. That is a risk factor in the form of immobilization. That is a risk factor in the form of immobilization. And in a patient who is immobilized and having a short history of chest pain and dyspnea, one of your important possibility is pulmonary thromboembolism. Is there any other clue that it is pulmonary thromboembolism? Is there any other clue that it is pulmonary thromboembolism? He is also having hypoxia. He is also having hypoxia. Do you remember yesterday I told you 2 characteristic features of pulmonary embolism would be a patient would have sudden onset breathing difficulty as well as hypoxia, right? As well as hypoxia, right? Okay. Now, can you see that? It is given in the question. These factors are given. What is that? Hypoxia, immobilization is given as a risk factor. Second thing, dyspnea is given as a manifestation along with hypoxia. So, I think in this particular patient, the probable possibility will be for which condition? Pulmonary thromboembolism. It is probably pulmonary thromboembolism. Now the question is, which investigation should be which investigation should be done for a definitive diagnosis? What is the answer? Answer is CT pulmonary angiogram. I hope all of you are able to understand this. This is a classical description of pulmonary thromboembolism. Some clues I have given, clinical clues I have given, and I have asked you for a definitive diagnosis. Answer is going to be CT pulmonary angiogram. Is that clear? Okay, right. Yes, correct. Okay. Just one thing. In the curve 65 score, I think I had mentioned blood pressure of less than 60 only, doctor. I think I had written 30 like that. Something I had written. Okay. Please change it, doctor, in the curve 65 scoring. I think I mentioned as 60 only, but I think wrongly written as 30. Okay. Please write it in the curve 65 score. Please write it. Blood pressure less than 90 systolic, less than 60 diastolic. Please change it. If I have written it in a different way, please change it. I think I had mentioned only 60, but while writing, I have written as 30. Okay, so please do change it. Okay, right? I think it's a error from my side while writing it. I had mentioned only 60 at the time of speaking, but while writing, I had mentioned as 30. Okay, so please note that confusion. This is for the curve 65 score. Please do note that. Okay, curve 65 score. Okay, Lucas? Yeah, right. Okay, fine. So that is done. We will move on to the next one. Next one will be question number 11. Okay. All are true about aspirin sensitive asthma, except I told you in aspirin sensitive asthma, there's a triad called Samter's triad. I have told you this yesterday. Samter's triad. And there are three things in the Samter's triad I had mentioned. What are the three things? One was association with nasal polyp and sinusitis. It is definitely there. Second thing was aspirin exposure. Okay, And third thing is presence of asthma. Yes. Now you look at the other two options. Which will be the answer for the question. Anyway, option A and C are correct ones. Answer is going to be increased prostaglandin. Why? I told you aspirin will cause COX inhibition, and it will decrease the levels of prostaglandin. Correct? Do you all remember that metabolic pathway I had discussed? Okay, it will decrease the prostaglandin level. It will not increase the prostaglandin. Okay, fine. So, of course, the other option, what is that? Treatment with inhaled steroid is correct because I told you one of the standard way by which we treat asthma is by giving inhaled steroid. So that is also a correct statement only. Okay, very obvious wrong answer. The answer for the question will be increased prostaglandin. It is actually decreased prostaglandin. I hope all of you can follow that. That will be question number 11. Then we move to question number 12. Two statements about emphysema include all of the following except. Okay, right. Look at the first one. Cyanosis. Will you get cyanosis in case of emphysema? Cyanosis is usually not a feature of emphysema because in emphysema, I told you there is absence of cyanosis. And do you remember how I mentioned emphysema cases as pink puffers? Pink here refers to absence of cyanosis. Puffers here refers to the association with smoking. Where do you get cyanosis? Cyanosis is a feature in another COPD, which is chronic bronchitis. Okay, chronic bronchitis. I hope you can remember the term I used for chronic bronchitis also. What is that? It's called blue bloaters. Correct. Blue bloaters. Don't forget this. Okay. Cyanosis is not for emphysema, it is for chronic bronchitis. Okay. Barrel-shaped chest is a very classical feature of emphysema. I told you. Due to what is the reason for this barrel-shaped chest? Due to hyperinflation. There will be a barrel-shaped chest. That's a correct statement. Associated with smoking is also a correct statement. Type 1 respiratory failure is also a correct statement. Don't forget, where do you get type 2 respiratory failure? It is in chronic bronchitis. I told you, B. You remember for bronchitis, blue bloaters. Okay, and B is the second alphabet. So I asked you to remember like this. You remember as type 2 respiratory failure. Correct? Type 2 respiratory failure. Okay, are you able to follow this, right? So that will be for this particular section, okay, which we should know about. Type 1 is for emphysema only. I hope you're able to follow this. These are some of the important MCQs related to our yesterday's discussion, topic of respiratory disorder. So I hope all of you were able to solve the questions related to this and could be able to read the topic of respiratory disorders also. Okay. I got a lot of messages. I could not reply to all of them. Okay. I was just replying to a few of them and few I could not get time. So those messages I have missed, I will reply today. Okay. Fine. Yes. So I hope any doubts, please keep letting me know in my Telegram thing. I will be able to reply there. Okay. Right. So I will share with you the entire this question and answers along with the writings after the class during the break time. I will share it with you. Okay. Fine. So our section of respiratory disorders is done, and we will move on to the next chapter today for discussion, which will be about neurological disorders. Okay, it will be about neurological disorders. You can take from your notes also. Okay, right? You can take from your notes. Okay, right. So I hope all of you have taken the worksheets. I hope all of you have taken the worksheets. Yes. Can we start the session? Okay, so we will be starting with neurological disorders now. Okay. Now this neurology is a very important section actually. Okay, right? And I have seen in your exams many questions have been asked from this neurology section. Okay, many questions have been asked from the neurology section actually. Like at least 5 to 7 questions. Okay, 5 to 7 questions every year in the exam. I see questions from neurology. Okay, and fortunately for your exam, they are asking only standard topics. They are not asking you very extensively. That is one good thing. Second thing, the type of questions are asked in such a way that if you know basics of that particular disorder, you will be easily able to answer this. And as I told you for many other, yesterday also I mentioned that whenever you study about a disorder, you focus about the important clinical aspects of that particular disorder. Because whenever you solve a clinical scenario question, we should make a distinction, right? What could be the possibility like that? Okay, for that, your knowledge about clinical features of the disorder will help you, and that is what I will also be focusing on as we keep discussing. Neurology, I'm starting the discussion today. By tomorrow afternoon only, I will be finishing this particular neurological disorders because it's relatively a long chapter actually. Okay, right? And tomorrow in the afternoon, after afternoon session I'm talking about, I will be discussing cardiology also. Okay, right? Cardiology again will take 1.5 days. On Saturday, I'm not able to take the class. That is day after tomorrow, I'm not able to take the class. So that class has been shifted to a later date. And during that day, okay, I will be remaining the rest of cardiology also. Okay, so that is what is the plan of discussion from my side. Today and till tomorrow afternoon, it will be neurology, and after that, it will be cardiology. Okay, cardiology is also another important section, which we'll try to discuss it in a very detailed way. Okay, right? Neurology, around 5 to 7 questions. Cardiology, again, 5 to 7 questions. Every year in your exams, you will get. Okay, fine. So let us get started. Yes. So the focus of discussion, see, the neurology section will be little difficult to follow or little difficult to, read about. I will try to make it in a simpler way. Whatever I am discussing here, if you can know it very correctly, it will be more than enough. Okay. Don't try to read too much in neurology part because it can be easily confusing. Okay. Only one thing I would have expected was the physiology chapters to be over because neurology has got a strong correlation with physiology also. Okay. But anyway, certain relevant things I will discuss then and there when I'm discussing few topics. Okay, fine. So let us get started with the a topic called headache. Okay, now this is a very common topic, but the point to be noted is headaches can be either benign condition, means not so serious condition, or it can be a sign of a severe disease also. First thing we will learn is how to differentiate whether it's a benign type of headache or it's a dangerous type of headache. Okay, right? And the initial category, I'm going to discuss about this headache part only. Please remember, headache is divided into 2 further types actually. One is called primary headache, other one is called secondary headache. Now, primary headache are the ones which are of common type. Primary ones are the common type. Primary ones are the common variety. What is the meaning of primary? Any of you know about this? What is the meaning of primary? We are going to discuss first about primary headache. Primary headache is a condition where there is no underlying cause. Where there is no underlying cause. Just like that headache occurs. There is no reason for this. No underlying cause. I think all of you might have heard about a condition called migraine, right? I'm sure most of you must have heard about this condition called migraine. That's a type of primary headache where you don't have any particular cause. Okay, where you don't have any particular cause. That is what is called as a primary headache. Okay, right? Secondary headache is something which is associated with some other condition. There can be some other associated condition. Okay, associated with other disorders. So as a part of other disorder, it occurs. For example, patient is having a hypertension and he is having a headache, then it is called secondary headache. Patient is having something like a brain problem, like a tumor inside the brain and having headache, that's a secondary headache. Patient is having an infection and having a headache, that's also a secondary headache. So what I'm trying to tell you, secondary headache is associated with some other disorder. That is the point. Okay. And most common of this secondary headache category would be something which is associated with infections. What is the infection I'm talking about? Where headache is a feature. Obviously, what is a common infection related to CNS? It is nothing but meningitis. Correct. It is nothing but the meningitis. It is nothing but meningitis. Yes, correct. It is nothing but the meningitis. Okay. So first get this clearly. that primary headache is something which is not having any other cause, but secondary headache is something which is associated with another disorder. That's what you should remember, primary and secondary. First, we will see about the common variety, which is the primary headache. And there are three important primary headache which you should remember. And three important pictures also. Just for a quick recollection, I have put here. Can we rename these primary headaches? Can we rename these primary headaches? Okay, three important names, don't forget. One is called tension headache. Another one is called migraine headache. Third one is called cluster headache. Three very, very important topics. Okay, three very, very important topics. Of course, the common one which most of us know about is the migraine. As some of you are already saying, it is migraine. Okay, now these three pictures represent the three types of headache. Okay, something like the areas where the patient actually feels headache. Number one, it is in the same order. First picture is for the tension headache, number one. Number two is for the migraine headache, second one. Last one, third one is for the cluster headache. This is how it typically appears. Okay, just have a look at the locations. Okay, just listen, just see the picture once and have a look at the locations. Okay, tension headache number one, number two is migraine, and number three is a cluster headache. What are the broad things you are looking at? Tension headache is something in the forehead area, here, forehead area. Migraine headache is something which one half of the face is affected. Cluster headache, very characteristic. What is that? Something surrounding the eyes. Something surrounding the eyes, it is usually noted. These are the typical locations of the three important headaches. Okay, these are the typical locations of three important headaches. Okay, fine. Now I am going to discuss all of them in little bit of detail because you get something like clinical scenario questions. They give you like clinical scenario and they ask you what is the condition you are dealing with. Like that they ask the questions. Okay, right. Now, which do you think out of these three things is the overall commonest type? Okay, overall commonest type. Canadian, which do you think is the overall commonest type? Yes, very, very correctly said. See, we might have heard about migraine as the commonest type, right? We might have heard about migraine as a very common thing, but actually, migraine is not so common. The most common type of primary headache is tension headache, right? Very correct. The most common type of primary headache is tension headache. Migraine is something which is discussed frequently. Many of us may have come across the term, but the overall commonest one is tension headache. And as some of you were saying very correctly, this tension headache is something which is related to stress. It is related to stress. Okay. And I think at some point of time, all of us must have experienced this. Okay, right? Something like yes, during this preparation time only. Okay, during this preparation time, we might have attended the classes from the morning till evening. Okay, online classes. Okay, and continuously you're looking at the screen, continuously making notes, writing like that with small breaks in between. Still, at the end of the day, okay, after the classes are over, okay, when you freshen up at the time, you will feel something like a not like a headache actually, something like a heaviness. Okay, something like a feeling in the forehead area. I think all of us must have experienced at some point of time. Okay, right? That is what is actually the tension headache. Tension headache is something which is related to stress. And what is the character of this tension headache? Can you see which area it is present? It is in the forehead area. Okay, something like a band put over the head. Okay, you can imagine like this. Something like a band is put over the head like this. That is what is the classical description also. It's a tight band-like headache. Very important. It's a tight band-like headache. Don't forget this. That is a number one. Number two, is it unilateral or bilateral? It is on both sides. It is present, correct? It's a bilateral headache. It's a bilateral headache. And number three, this headache is not something which will be continuously present. Okay, it would be something like present at some time and then gets relieved, then again comes back, then again gets relieved. Okay, this is what we call it as a intermittent headache. It is called as an intermittent headache. It's called intermittent, means in between it is happening, not constantly present. That's what I'm trying to say. And this is what we call it as a waxing and waning type. Waxing and waning. Increasing, decreasing, increasing, decreasing. That is what we call as a waxing and waning type of headache. Very classical type. Most important clue is that something related to stress and something which is seen in the forehead area. Are you able to follow this? Something related seen in the forehead area. Are you able to follow? Okay, right. Is that clear? Are you able to follow this? Okay, fine. Now, what do you think would be the treatment for this tension headache? Do you want to treat this condition with any heavy drugs and all? Not at all required. Most of the times, if you take rest itself, if you divert yourself to some other activity itself, that will relieve this particular headache. But if at all you want to have any medication which will settle this condition, a simple paracetamol would help. Okay, a simple paracetamol would help. Okay, so the drug for this particular condition is a simple paracetamol. That's all. You don't need to take any strong medications and all. Okay, it will get settled on its own mostly. But if you want to use a drug, it should be paracetamol. That's all. So that is about number one, which is the tension headache, the most common type of headache. Then we move on to the second one. This is the second one. What is that? Second one is the migrainous headache. What is the classical feature of that migrainous headache? You can see it is like one half of the face fully getting affected. Now, migrainous headache is something which most of us might have heard about. We might have heard about relatives, patients saying that I'm having migraine and all. But let me make it very clear that most of the times what we hear as migraine is actually not migraine. Okay, because migraine is something which will have a strict set of criteria to be followed to make the diagnosis. Many of them say migraine, migraine like that, but in reality, I'm going to tell you the criteria. If you apply all of that, you may realize that it was not actually a migraine. Out of 10 cases you hear as migraine, if you apply the criteria, only 3 or 4 will fit into this. Remaining 5 or 6 is not actually migraine. Okay. So please make sure you know about this topic, not only for your MCQ purpose, but in future also, whatever specialty you take, you will come across a patient who says that I'm having migraine. Carefully assess them whether they are having migraine, because actually, if it is a migraine, your treatment should be a very strong treatment. If it is not a migraine, even a paracetamol would help in that patient. That is a simple thing which I'm trying to tell you. So please make sure you know the correct criteria for migraine and don't just try to overdiagnose this particular condition. Okay. So for that only, I'm going to tell you a strict set of rules or criteria to diagnose this condition. First thing, where is migraine common, males or females? It is more common in females compared to males. That is the first point to be noted. It is more common in females compared to the males. That is the first point. Second thing, we always follow something called as a rule of 5, 4, 3, 2, and 1. What is this interesting rule? Okay, this is just not given in any textbooks and all. It is something which I follow to remember the features of migraine. And I think even for your exam purpose, you can remember this particular rule. What is that? Can you see that the first one, what is written? The first one is written as 5. What is that? 5 is something like the patient should have 5 or more attacks of headache. It is not just only with one episode, you will say that the patient is having migraine. No, it should be a recurrent condition. That is what I'm trying to tell you. It is going to be a recurrent condition. Please don't forget this. It's going to be a recurrent condition. Don't forget. Okay, it should be a recurrent condition. That is number 1. Okay, number 2, 4. What is that? The duration of the migraine headache. It is not going to be short duration, like few minutes and all. It can go on for few hours. Usually 4 to 72 hours. So what I'm trying to tell you, the patient can have one attack of migraine today, even till tomorrow also, he may be having continuously headache. So each attack of migraine will last at least 4 to 72 hours. Please make a note of this. That is for 4. There is nothing for 3 actually. You can just omit that part. There is nothing for 3 actually. Then I'm straight away going to the 2. What is that? Patient should have, in addition to migraine, at least 2 associated findings. At least 2 associated findings. Or, okay, 2 associated findings. Or you can just write, patient should have at least 2 of the following features. What is the type of migraine? That is what, or what is the type of the headache? That is what we are talking about. Remember, migraine headache is something which is little dangerous. Okay, dangerous. And if you have seen a patient with migraine, you will not forget how it would appear like. The patient will say that I cannot do any work once I get the headache. He will just be confined to one area and he will say, I don't want to be disturbed by anyone. I don't even want to look at anything. I don't want to hear any sound. I want to be isolated. So it's a very disturbing type of headache, first one. Second thing is that the patient will be just lying in one area. Because what he will say, even if I move from one place to another also, I start getting the pain. That is a very severe type of pain. And third is, of course, I have put it in the picture itself. What is that? It's a unilateral headache or bilateral headache. Usually it's a unilateral headache. And very, very important, the type of headache they say is more like a pulsatile headache. Okay, these are the characteristics of the migraine headache, which I'm going to make you remember like a mnemonic called DUMP. D-U-M-P. DUMP is a mnemonic which I use to remember the features of migraine headache. What is that? D for, it's a disabling type of headache. Are you able to follow? Disabling type of headache, meaning it's of moderate to severe intensity. You don't need to know what is moderate, severe, and all. There is also something called pain scales and all available. That and all is not asked for the exam. But only thing I want you to know is that it's a little severe type or a disabling type of headache. That's why I'm writing moderate to severe intensity. Okay, right. Then, what is that U for? U for unilateral headache. That's what I have shown in the picture. 70% cases or most cases actually unilateral headache. Why I want you to remember this point? Because 30% of migraine headache can be bilateral also. Please keep in mind. Okay, 30% case of migraine can be bilateral also. But don't worry about this fact that in your exams, if they want to ask you a question about migraine headache, they will mention only unilateral. I'm just telling you the practical thing, because in future, when you come across a patient who's having migraine and he says that I'm having headache on both the sides, don't think that I have brought you wrongly. Few cases can have bilateral headache, that's all. But for exam purpose, You just remember this picture and then you remember one thing. What is that? It is usually unilateral. That is enough. Okay. Then what is the next one? Movements. M for movements. Any movement will increase the pain. That is what I'm going to write. Any movements will aggravate the pain or increase the pain. Any movement will increase the pain or aggravate the pain. That's what you need to remember. And last one, please, for the nature of the pain. What is the nature of the pain? It is pulsatile nature, or some describe it as throbbing nature also. Okay, throbbing quality of the pain. Okay, these are the points I want you to remember for this particular migraine headache. Right? In the form of mnemonic, you can remember in the form of DUM. That is what it is. Disabling type, unilateral movements aggravate the pain, and pulsatile or throbbing quality of the pain. Okay, please make a note of this. Okay, fine. Then last one is the one. What is that? The patient should have one of the associated findings. What is the meaning? In addition to headache, they can have one of the associated findings. Any idea what finding they can have in addition to headache? In addition to headache, I told you already one of that. What is that? I told you they remain confined to one area. They don't want to see anybody. They don't want to hear any sound. In fact, if they hear a sound or any light, their headache will increase. And they say that I have a fear of sound. I have a fear of light at the time. What do you call that? Yes, photophobia. I think all of you know about this. Phobia means fear. Photo means vision or light, something like that. Then they also have fear of sound. What is that called? Phonophobia. Phonophobia. Okay, so light fear, sound fear would develop at that time. Or they can develop nausea or vomiting. Nausea or vomiting. You can see many patients like this. Okay, right? So either the photophonophobia or nausea vomiting would be an associated feature of this particular condition. Okay, please keep in mind. Yes, correct. Very correct, doctors. Correct. Okay, right. So this is something which you should remember about. So if you see the criteria I have given, it is not a very simple thing. Okay, it is not something like easily you can say all cases as migraine. Okay, you apply all these things. Okay, a patient should have multiple attacks. A patient should have long duration headache. A patient should have the quality of headache, which I have mentioned, like two of the features in the form of DUM, and any associated findings if they are present. Then only you say that this patient is having headache. So that is what I was telling. If you apply this criteria, you will actually know that not all patients who are actually saying migraine are having actually migraine. It may not be a migraine at all. That is what I'm trying to tell you. So migraine is something which is very dangerous, of course, true, but you should not over-diagnose that condition. You should diagnose only when all these set of findings are fulfilled. Okay, then only you can call it as a migraine headache. Okay. Now there are actually two types of migraine headache. Maybe in the top of the page you can write it. Where you have spaces by the side, you can write it. There are two types of migraine. One is called as a classical migraine. Another one is called as a non-classical migraine. Classical and non-classical migraine. This is based on the presence or absence of aura. Presence or absence of aura. Okay. Any of you know what does this aura means? Many times, no, not many times. Sometimes I'm talking about. If you know that this patient is actually having a migraine, they will tell you that when they are going to have an attack of migraine headache. Do you know what they tell you? I usually get a strange feeling before I start having the headache. Okay, have you noticed anything like that? Any of your, like patients or your relatives saying like that, who are having migraine, they actually tell, I have a strange feeling. It may be something like a sound here inside, or it is something like a feeling which they get inside, or something like sounds they hear, something like that, and then they start having the attack. And that strange feeling, which actually occurs before the my headache occurs, is what we call it as the aura. Have any of you noticed that? Have any of you heard about that? Something like that? Yes, that is actually called as the aura. So I will just write it in simple words. Aura is nothing but the warning signs or symptoms before an attack of migraine. Before an attack of migraine. Warning signs or symptoms before an attack of migraine. That is what we call it as an aura. And if aura is present, you call it as a classical migraine. If aura is absent, it is called as a non-classical migraine. Do you know? Yes, correct. Exactly like that. Something like flashes of light or abnormal sound or something like strange feeling they have inside. Then they say that, okay, I'm going to have an attack of migraine. Okay, that is called aura. Now, with aura is called classical migraine. Without aura is called non-classical migraine. Do you know which is the common type of migraine? Do you know which is the common type of migraine? It is actually non-classical migraine is the common type of migraine. Okay. So in future, suppose you are getting a clinical scenario question, don't expect aura to be given because that is not the commonest type. The commonest type is a non-classical type, which is without aura. Are you able to follow this? Okay, right. So please make a note of this. These are some of the important points regarding the features of migraine, which I want you to know about. Now, I told you migraine is not something which is a simple condition. It's a little dangerous condition. So you have to give something called specific form of treatment also. First thing, of course, patient himself will tell that I want to take rest. I don't want me to be disturbed by others. So you also advise the same thing to the patient. Rest, especially a good sleep, will help. Most of the patients tell like this. If they have a good sleep, that itself will decrease the intensity of the headache. So sleep is something which is very important as a part of management. And they should avoid all the triggers, like they should avoid the light, they should avoid the sound. It is best that the patient himself gets isolated in a dark room and stay there. And if possible, sleep for a good amount of time. That will actually decrease the intensity of headache. What are the drugs which you can use? You can use NSAIDs, non-steroidal anti-inflammatory like ibuprofen, indomethacin, all those things can be used. But 50% chance only that the patient will respond to NSAID. Remaining 50% of the patient, they actually experience a severe type of headache. And I think some of you will be able to answer this. What is the drug of choice for severe headache associated with migraine? What is the drug of choice? I think this some of you can answer. Very correct. The drug of choice is going to be very good. Triptans. Okay, a group of drugs called triptans. There are so many triptans available, like sumatriptan, rizatriptan. So many triptans are available. Triptans are supposed to be the drug of choice for this particular condition. And if you know what is the mechanism of action of these triptans, they are serotonin, that is 5-HT, agonist actually. But not all receptors of serotonin will be acted upon by tryptin. What are the receptors which are acted upon by tryptin? Yes, it is 1D, 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 1D agonist. That is the point. Okay, specifically for this type of receptors, 1D, 1D agonist. Why? Because serotonin has so many, serotonin has so many types of receptors. It acts on so many types of receptors, 5-HT1, 2, 3, so many things are there. And every receptor will produce different effect. I hope all of you know about this. Even in your classes, you used to study like that. But I am particularly saying that they act on 1D, 1D receptors only. So how do you think this is going to improve the headache? Okay, two areas it is going to act actually. First one is in the nerve. Second one is in the blood vessels. Okay, so you think like this. This is the nerve ending like this. I'm just drawing like a nerve like this. And this nerve ending, okay, from the nerve ending only, there is something called pain mediators which will be released. There will be something called pain mediators which will be released. There are so many pain mediators which you might have studied in your pathology classes and all. But important ones for the migraine and headache are one is substance P, which is actually related to what substance? Okay, bradykinin substance. It's a very, very important pain mediator. One more is called CGRP. What is that? Calcitonin gene-related peptide. CGRP, calcitonin gene-related peptide. These are the important pain mediators which are released from the nerve endings and are involved in the causation of pain in case of migraine and headache. Now, what the triptans will do? The triptans will act on these receptors. Here are the receptors, that is the 5-HT1B, 1D receptors. And when they act on the receptors, they block the release of pain mediators. Okay, that is how triptan acts. They block the release of pain mediators. So that way the pain intensity will decrease. Are you able to follow? Yes, very correct. Second thing, it is noted that in the blood vessels, there is vasodilatation at the time of headache. Now, what the triptans will do? Triptans will act on the 5-HT1B, 1D receptor on the blood vessel also, and they cause vasoconstriction. And whenever vasoconstriction occurs, that also will decrease the headache. So these are the two ways by which triptans are going to act and cause decrease in intensity of headache in case of migraines. And triptans are supposed to be the DOC. What is that? Drug of choice in the treatment of migraine. Okay, right? So all these points are very, very important, which you should keep a note of, has been asked in the exams. Okay. Able to follow this, right? So these are the treatment options which we have for a patient with a migraine. And the drug of choice, don't forget, it's a very important question. It is always triptans. That will be the drug of choice. Okay, fine. Now I told you, migraine is a condition which can have repeated attacks, correct? Migraine will have repeated attacks. So obviously, in future, you want to decrease the attacks in that patient, correct? You want to decrease the attacks in that patient because you don't want the patient to suffer from repeated episodes of migraine. So what you can give for prophylaxis? What drug you can give for prophylaxis? This by itself is a pharmacology question, which I think some of you must have heard about it already. The first line medication or the usual prophylaxis which we give to all patients with repeated attacks of migraine, what is that? It is nothing other than beta blockers. Propranolol. Okay, it is nothing other than the beta blockers, which is the propranolol. That is number one. Number two, tricyclic antidepressants can be given, TCAs can be given, okay, like amitriptyline, all those things can be given. Third one is another, is an anti-epileptic medication, which is topiramate. That's what we give. But if you want to remember simply only one drug, please by heart this beta blocker. That is what we commonly give as prophylaxis for this particular condition. Second line medication is another anti-epileptic medication. Any of you know what is that? Any other anti-epileptic medication? Second line, it is valproate. And I have seen in a good number of clinical settings, like in OPs and all, valproate is also being used. Okay, valproate is also being used. Okay, but anyway, commonest one is propranolol or beta blockers. That's what you should remember. Other medications are like second or third choice drugs like that, which we usually don't use it. Okay, but I have seen personally that in many centers they're using valproate also. Okay, fine. But for your exam purpose, remember beta blocker. So drug of choice for treatment of an acute attack of migraine, it is triptan. And drug of choice for prophylaxis would be beta blockers. Are you able to follow this, right? So these are some of the characteristic things about this particular what is it? This migraine, which you should know about. Okay, so two things are over. One is the migraine, another one is the tension headache. I told you most common is the tension headache, but the last one, what is the last one? Cluster headache is supposed to be the most severe type of primary headache. Please note it here. Cluster headache is supposed to be the most severe type of primary headache. I will try to explain this particular condition. Okay, I will try to explain this particular condition. Okay, fine. Why it is most severe and all, I will tell you. Now, what is the one which you are seeing from the picture? It is something which is surrounding the eyes. Okay, something which is surrounding the eyes, correct? Okay, it's periorbital. Now, you please write about some of the important points about this cluster headache and start writing from here. Yes, I've already told you it is the most severe type. And what is the location? That's what I have told you already. It's a periorbital. Now, whenever I say periorbital, can any of you think about a nerve which is actually in that particular area? Can you think about a nerve in that area? Something surrounding the eyes and all? Which nerve, which cranial nerve is related to that area? It is something like, yes, trigeminal nerve. It is a trigeminal nerve, and that too, ophthalmic division of the trigeminal nerve. Okay, it's ophthalmic division of the trigeminal nerve. Ophthalmic division of the trigeminal nerve. Okay, right. So this is a condition. So this is a type of headache which is somewhere other related to a nerve. See, there are so many theories regarding this cluster headache. Some are saying that it is directly related to the nerve only, and some are saying that it may be just because of the location. It is looking to be very severe. Okay, but nobody knows the exact reason. But what I can tell at this point of time is something related to that nerve. That is why that area is actually affected. And this condition is of duration, relatively longer duration only, but not so much like a migraine, but around like 30 minutes to 3 hours. 30 minutes to 3 hours. And these patients, they will have multiple episodes. They will have multiple episodes. So many things, like almost like what multiple episodes, around like 3 to or 5 to 8 times per day. They have so many multiple attacks during the day. Okay, 5 to 8 episodes per day. And usually at the night, they have the symptoms. And what I'm trying to say, the patient will wake up with attacks of migraine in the night time. Okay, just give me a minute. Just give me a minute. Okay, fine. That's okay. Okay, right. They have multiple episodes, especially during the night time. Often occurs at the night time. So that's what you should know about. Okay. So please make a note of this. Location will be periorbital, relatively longer duration, but not so long like a migraine. But they have multiple episodes, and usually no triggers are noted. No triggers are noted. Okay, right. So one reason why it may be appearing as a severe type of headache means it may be related to a nerve directly. That is why I'm saying it's a severe type of headache. Second thing is because of the additional features which are noted in this particular condition. Okay. See, you all know that, okay, whenever the cranial nerves come out, I'm talking about the nerves which are coming out. What is the nerves which are coming out? Like the vagus nerve, trigeminal nerve, facial nerve, and all, when they come out, they also carry with them something like the sympathetic and parasympathetic fibers also along with them. I think you all must have heard about that. Okay, in your anatomy classes, you might have heard that these cranial nerves carry along with them some sympathetic and parasympathetic fibers also. So what they are saying, because I said this condition is something related to the nerve, cranial nerves, it can also have autonomic features. They can also have autonomic features. Autonomic means what I'm talking about. Autonomic means I'm talking about sympathetic or parasympathetic manifestation. Here it happens to be parasympathetic activation in this area. Parasympathetic activation. So now can anybody tell if parasympathetic activation is going to occur in this area, what all features we are expecting? Think about this eye area, face area like that. There is parasympathetic activation happening. So what will be the features? Parasympathetic activation will result in increased amount of secretions of the gland in that area. For example, eye area, the glands are secreted. What will happen? Lot of tears or the eye, water will come out from the eyes in increased amount because of increased secretion from the lacrimal glands. What do you call it? Increased lacrimation can occur. Increased discharge from the eyes can occur. Increased discharge from the nose can occur due to secretion of the nasal glands. What is that? Rhinorrhea, running nose. Anything else can happen? The conjunctiva will become congested. Conjunctival congestion also will be noted. These are all features of parasympathetic activation. These are all features of parasympathetic activation, which is noted in this particular condition. Very correct. Okay, right. Now, very small percentage, that is 20% of cases, they have Horner syndrome. 20%, very small percentage of cases, they have Horner syndrome. Okay, right? They have this Horner syndrome. And if Horner syndrome, why not optic nerve? Optic nerve is something which is inside. Okay, optic nerve is something which is inside. I'm talking about trigeminal nerve and the surrounding nerve fibers. Okay, right. Yes, what is that? Yes, I was talking about Horner syndrome, right? 20% of the patient will have Horner syndrome. 20% of the patient will have Horner syndrome. And I think some of you must have heard about this Horner syndrome. What are the findings which I have put up in this particular question? This side is the side where the patient is having the Horner syndrome features. What are the features this patient is having? Obviously, you can see there's a drooping of the eyelid. What is that? Ptosis. What is that? Compared to this, you can see this is the size of the pupil on this side. Here, the pupil is small in size. What is that? Meiosis. Ptosis. The second manifestation is meiosis. And third manifestation is anhidrosis. Anhidrosis. Okay. Ptosis, meiosis, and anhidrosis. Ptosis, meiosis, and anhidrosis. What is the meaning of anhidrosis? It's not given in the picture, but what is the meaning? Decreased amount of sweating on the affected side. Decreased amount of sweating on the affected side. Anhidrosis. Okay. All right. Now, can anybody tell me what is the reason for this Horner syndrome? It is due to interruption of the sympathetic nerve fibers. It is due to interruption of sympathetic nerve fibers. Due to interruption of the sympathetic nerve fibers, only you get the Horner syndrome. Due to interruption of the sympathetic nerve fibers, you get Horner syndrome. Just make a note of it. That's enough. Okay, so that is what I was trying to tell you, that this condition appears to be dangerous. One, because it is related to the nerve. Second, it can have autonomic features. These are the two reasons why this condition is considered to be a severe type of headache. Are you able to follow this? Okay, right. Yes, very good, everybody. I think there is some delay in the time when I am speaking and when you are receiving the actual, video. I think there's a small delay. So that is why I can see the messages in my other screen, but it's all coming a little late. I think the issues that the streaming has been, there is a delay between what I'm speaking and when you are hearing the same thing. So there's a small delay, but it's okay. During the next, during the next video session, I will ask them to make it synchronized. Okay, but I think there's a small delay. That's what I can see. Okay, that is fine, but it's okay. We can continue the discussion. Okay, you can have your comments also. I will be able to see them in between. Okay, fine. Okay, so again, telling cluster headache is a dangerous type of headache because two reasons. One, it is related to the nerve. Second reason, it can have a lot of autonomic manifestation. Okay, fine. Now, cluster headache, I told you, is a very severe type of headache. So obviously, what should be the treatment you should give? Obviously, here also, the drug of choice would be again triptans. Okay, drug of choice would be again triptans only. And in addition to triptans, what they are saying is you should also give O2 inhalation. That to high levels of oxygen inhalation, 100% O2 inhalation is also an important part of management. But if they ask you the drug, you can just stick to triptans. That is more than enough. But O2 inhalation also is helpful in this particular condition. That's all. Okay, so these are the important things about cluster headache which I want you to remember. Let us just have a quick review about this cluster headache. Oh, sorry, 3 types of headaches. Okay, what is that? Most common one. Overall, most common one, it is tension headache. But tension headache is a benign type of headache. It will simply respond to paracetamol and it is a band-like headache in the forehead area. That's all. Over. Number 2 will be the migraine headache. Migraine headache is something which is little severe quality. Okay, and it is usually unilateral headache. And don't forget the rule I told you, 5, 4, 2, 1. It should be recurrent attacks of severe headache lasting at least 4 hours duration. And it should have one of the associated features like photophobia, phonophobia, or nausea and vomiting. Any one of the associated features should be present. Then you can call it as migraine. And for migraine, the drug of choice is triptans. And for drug for prophylaxis is beta blockers like propranolol. Last one is the dangerous one, which is the cluster headache. This is supposed to be dangerous because of neurological involvement, probably, which now we were talking about. It is a ophthalmic division of the trigeminal nerve. That is why it is surrounding the eyes only. And second important association for cluster headache is the autonomic manifestation, especially increased parasympathetic activation. And few cases will have Horner syndrome also. And again, here also, the drug of choice is going to be, what is the drug of choice? The drug of choice is going to be triptans only. That's all. So these are the important points about the types of primary headache, which you should know for your exams. Okay. Then we move on to the secondary headaches. I told you for secondary headaches, it is something which is associated with other problems like trauma to the head, infections of the brain, or it could be something like hypertension. It is something like secondary headache. And in the secondary headache category, one which I'm going to discuss in detail will be something related to intracranial bleeds. This is a topic by itself. I think even in your surgery classes, they will be discussing about intracranial bleeds also. Okay, because most of the intracranial bleeds are related to trauma, like road traffic accident. This is the common type, trauma-related intracranial bleeding. But some cases of intracranial bleeds can also be non-trauma related also. Okay, right? Can we tell what are the trauma-related intracranial bleeds you know about? What are the trauma-related intracranial bleeds you know about? Yes. Okay. Three important names should come to your mind. Trauma-related intracranial bleed. One is SAH. What is that? Subarachnoid hemorrhage. Then SDH, which is subdural hemorrhage. Subdural hemorrhage. Yes. Third one, EDH. What is EDH? Very correct. Epidural or extradural. Both are same names only. Epidural or extradural hemorrhage. Epidural, extradural hemorrhage. So these are the three trauma-related names which you should remember. Okay, right? Subarachnoid hemorrhage, subdural hemorrhage, and extradural hemorrhage. Most important, which I'll be discussing first, will be the subarachnoid hemorrhage. Okay, right. Fine. Any of you know any non-trauma-related condition which can cause bleeding in the brain? There are so many conditions actually, but most common in this non-trauma-related bleeding would be something related to hypertension-associated bleeding. Hypertension-associated bleeding. Hypertension-associated bleeding. Okay, most common will be hypertension-associated bleeding. What type of bleeding it produces? It typically produces bleeding in the brain. What we call it as intraparenchymal bleed. I hope you can understand the meaning. Intra means inside. Parenchyma means the brain parenchyma I'm talking about. Intraparenchymal bleed. And this is a very famous question they're asking in your exams nowadays. Which is the most common location of hypertension-related bleeding in the brain? They ask you which area, like thalamus, hypothalamus, like that. They are giving you options. Any idea what is the most common site of hypertension-associated bleed? And if you know that, and if you know, most common cause of hypertension-associated intracranial bleed or intraparenchymal bleed. Very good. The location is putamen area. It is putamen area. It's a many times repeatedly asked question. I'm putting Q there just to make you remember. It's a repeatedly asked MCQ question. So please make a note of it. Very correct. Okay, putamen-related bleed. Putamen bleeding. You all know putamen is a part of basal ganglia, correct? Okay, that is where actually the hypertension-associated bleeding is noted. Okay, so that's about a brief introduction to the intracranial bleeds I have told you. Now we are going to discuss about some conditions in detail, starting with subarachnoid hemorrhage. Okay, this will be the first topic of discussion, subarachnoid hemorrhage. Right? Every year, okay, take my words, every year, either in the June exam or in the December exam, we have one question compulsorily from this subarachnoid hemorrhage. And if I'm not wrong, even in this January exam also, we had one question from subarachnoid hemorrhage as a short case scenario type question. Okay, I will tell you what are the catchwords. Please remember those catchwords because that will be definitely be given in your exam to give you clue that it is a subarachnoid hemorrhage. Okay, right. I think all of you know subarachnoid hemorrhage is something related to subarachnoid space. Where is the subarachnoid space? Where is the subarachnoid space? I think all of you know where is the subarachnoid space between the arachnoid and the pia mater. And bleeding into that area is what we call it as a subarachnoid bleeding. That is what it is. Okay, I think all of you know subarachnoid place is also the place where the CSF is present. Okay, I think all of you know about these facts. Okay, so let us get started with the topic of subarachnoid hemorrhage. Subarachnoid hemorrhage can either be a primary type or a secondary type. What does it mean? Primary type means without any factor, spontaneously there is a bleeding. Then it is called primary subarachnoid hemorrhage. But the common variety is not primary. The common variety is what? The common variety is a secondary type. What is the meaning of secondary? Secondary means due to some other problem, there is a subarachnoid hemorrhage. It is usually due to some other problem, there is a subarachnoid hemorrhage. Do you know what is the commonest cause of the subarachnoid hemorrhage? It is usually due to a trauma like RTA, road traffic accident. That is the usual scenario where patient develops bleeding in the subarachnoid space and has a presentation. That is what you need to remember. Okay, very correct. Yes, very correct. Okay, so subarachnoid hemorrhage is of two varieties, primary and secondary. Secondary is the common variety, which is usually due to a trauma. Then, what is the reason for primary hemorrhage or the spontaneous subarachnoid bleeding? Any idea? What is the reason for primary spontaneous subarachnoid bleeding if it is not due to trauma or any other condition? Why do you think bleeding should occur in the subarachnoid space? This is due to something called as rupture of a aneurysm. Any of you know the name of that aneurysm, which when ruptures can result in subarachnoid bleeding? Yes, it's a very important aneurysm named Berry aneurysm. Okay, it is something called as Berry aneurysm. Okay, right? It is due to rupture of the berry aneurysm. Few points about this berry aneurysm you should be knowing about. Few points about berry aneurysm, please know about. From the next page, I'm going to discuss that. See, berry aneurysm is something like when we are born itself, that berry aneurysm is present. So it is something like, I think all of you know, aneurysm means dilatation of a part of an artery, but it is like a congenital condition. It is like a congenital condition. That means whenever we are born itself, that berry aneurysm is present. But what is the point about berry aneurysm? Most of the times, the berry aneurysm is something which is harmless. Patient will not suffer from any symptoms due to berry aneurysm. That is what our teachers used to say. We live and die with the berry aneurysm most of the time. That means usually they don't cause a problem. That is what I'm trying to tell you. But very, very rarely they can rupture, and that rupture can result in subarachnoid bleeding. That is what I'm trying to tell you. Okay, now next, whatever I'm going to tell you are some facts about berry aneurysm. You can see what is the location of the berry aneurysm. The clue is here. What is this picture depicting? This picture is depicting what? This picture is depicting the well-known circle of Willis, right? It is a well-known circle of Willis. So berry aneurysm is somewhere related to the circle of Willis. I think all of you know about this. Circle of Willis is the area where all the arteries supplying the brain are getting interconnected, namely the anterior cerebral artery, posterior cerebral artery, middle cerebral artery. Everything is getting connected with each other and forming a circle on the back of the brain. That is what all of you must be knowing about circle of Willis. And can you see all these small dilatation? These are the berry aneurysms only. Are you able to follow this? And can you see out of the different areas I have mentioned, which is the most common site? Can you see that? Which is the most common site? It is here. The most common site is here. What is that? 40% of cases are involving which artery? 40% of cases are involving this artery. What is that? Anterior communicating artery. Can you see that? Okay, so the most common site of berry aneurysm you are going to write is anterior communicating artery. 40% of the cases are located there. Anterior communicating artery. That's what you need to remember. A. Okay, anterior communicating artery. That is what you need to remember. Okay, now I told you most of us have berry aneurysm, but we do not suffer from subarachnoid hemorrhage. Only few can suffer from subarachnoid hemorrhage due to rupture of the berry aneurysm. And what are the factors which will predispose to rupture of this berry aneurysm? Any comment? Number one factor is always going to be smoking. Number one factor is always going to be smoking. Number one factor is going to be smoking. Cigarette smoking is the number one risk factor for rupture of berry aneurysm. Number two risk factor is uncontrolled hypertension. Uncontrolled hypertension. These are the two important risk factors for rupture of berry aneurysm. Other factors are also there. I just quickly write it. Number three would be age, more than 40 years. Number four, of course, size. If it is big size, it is easily going to get ruptured. More than 10 millimeter in size, then also it can be ruptured. Okay, more than 10 millimeter in size, it also can be ruptured. Okay, and what I want you to remember is which location of the berry aneurysm is more prone for rupture. I told you the most common location is here. What is that? Most common location is anterior part, anterior communicating artery. But whatever berry aneurysm is located on the posterior side, please see here. Only 4% of cases are there in the posterior side of the circulation, posterior communicating artery, posterior cerebral artery. But if the posterior circulation, you have a berry aneurysm, that is associated with the increased risk of rupture as well. This is more like a theoretical question, but important for the exam. Okay, posterior circulation berry aneurysms are more prone for rupture. Okay, so please make a note of this. All these are important points which you should be knowing about. Okay, right? Okay, right. So whatever I have told you is facts about berry aneurysm. Just keep in mind, berry aneurysm is a congenital condition. By birth itself, it is present. Most of us do not have a problem, but few patients, okay, the berry aneurysm will rupture, and there are few risk factors also I have told you which can promote rupture of berry aneurysm. Okay, and berry aneurysm associated subarachnoid hemorrhage is what we call primary subarachnoid hemorrhage. But the commonest type is the secondary subarachnoid hemorrhage, which is something associated with trauma, right? Road traffic accidents. Are you able to understand till this point of time? Okay, now let us see how a subarachnoid hemorrhage will present there. Look at the wordings I have written. Of course, we are discussing under the category of headaches only. So definitely patient will have headache. But this subarachnoid hemorrhage headache is supposed to be having this characteristic name. What is that? Worst headache of his life. This is how the patient will describe. I have the worst headache of my lifetime. That is how they are going to describe. Till now, I have not experienced this. Any other name for this headache also being used? Any of you know about it? Any other name for this headache? It is also called thunderclap headache. Don't forget this. It is also called as a thunderclap headache. Don't forget this. This is very, very important. Thunderclap headache. Very important point. Please don't forget this. It's also called as a thunderclap headache. Means it's like a sudden thunder falling on your head. Something like that. Okay, right? It's called thunderclap headache. Okay. Next thing, subarachnoid space, right? That is what is involved. Now you all know that subarachnoid space is not only in the brain, it is also in the spinal region. Okay, it is also surrounding the spinal cord. I think all of you know about this. Meninges will surround the spinal cord also. So you can have pain in the neck area related to the cervical part of the spinal region and cervical part of the meninges. So they will have what? They will have pain in the neck also. What do you call that? Neck rigidity. They also have neck rigidity. They also have neck pain or neck rigidity because subarachnoid space is present in the neck area also. Now, whenever I say neck rigidity, very good. Whenever I say neck rigidity, any other condition comes to your mind? Any other disorder also you will have characteristic neck rigidity? Can anybody tell me? Any other right? Any other condition also you can have neck rigidity? Yes, it is meningitis. In meningitis also typically you study about neck rigidity. But please remember, in meningitis is an infection. Okay, so what you will have? You will have fever also associated. But subarachnoid hemorrhage is not an infection. So in this particular condition, there is absence of fever. This is important. There is absence of fever. That's what you need to remember. Very, very important point again. There will be no fever. And third important thing is, this is something which is outside the brain, correct? Meninges are like covering of the brain. It is not inside the brain. It is outside the brain. It is present. So you will not have any neurological deficit. No focal neurological deficit. The patient will not have weakness of the limbs. Patient will not have speech difficulties, something like that. So no focal neurological deficit. All these 3 points are very, very important clinical characteristics of subarachnoid hemorrhage, which will always be given in your exam, based on which you type, okay, probably this is a case of meningitis or it is subarachnoid hemorrhage. I hope you're able to follow this. Please don't forget, this is all very important for exams. Okay, these are the features of subarachnoid hemorrhage. Okay, are you able to understand this, right? These features will be given, I think, in your January exam also. One of the questions based on clinical features of subarachnoid hemorrhage was given in the actual exam. Okay, right. So these are the features which I want you to make a note of. So now let us imagine that we had a patient who had some sort of trauma in the head, and then he presented to the emergency room, and he was saying all these features. I'm having a burst headache, and I'm also having a neck pain like that. But examine the patient, there's no fever, no focal neurological deficit. You are convinced that this is a case of subarachnoid hemorrhage. What do you think is the imaging modality? Now, this imaging modality is not only for subarachnoid hemorrhage I'm talking about. Any patient with a trauma to the head, what is the imaging modality you will always perform? This is a repeatedly asked MCQ question. Will you perform X-ray of the skull? Will you perform CT? Or will you perform MRI? That is the options. Okay, you have to choose among these 3 options. What is the imaging you will do for any patient who is presenting with a trauma to the head and you are suspecting some problem due to that? X-ray, CT, or MRI. Very good. It is CT, and to be very specific, non-contrast CT of the head. Very, very important. Non-contrast CT. Short forms, you remember NCCT. This will be the investigation you should always perform. I am happy that most of you are able to tell the answer. Right? Non-contrast CT is what you are going to see. And how do you see the bleeding in the CT and all? Will it be white in color or black in color? It will be something like this, white in color only, and you can see something like a white area here. Can you see that? All these white areas. These are the white areas which are representing the bleeding. Can anybody comment on the area which I am telling? See, meninges is something which is surrounding the brain, but there are so many folds in the brain also. Through that folds also the meninges will enter in and come out, right? So don't think that it is inside the brain and all. No, it is in the brain. It is in the meninges area only. But through that, partitions of the fissures, the meninges is entering inside. Can anybody identify this area? That is what I'm trying to ask you. What is that area where you have this white color or the bleeding manifestation? Very good. It is the bleeding in the sylvian fissure. It is blood present in the sylvian fissure. That is a keyword which I want you to remember. Blood present in the sylvian fissure. Don't forget this. This is important. Presence of blood in the sylvian fissure. Okay, don't forget this. This is important. Presence of blood in the sylvian fissure is a diagnostic finding of subarachnoid hemorrhage. That is the point I want you to remember. This is the usual investigation which you do for all patients with subarachnoid hemorrhage. Okay, just for academic purposes, I am also going to tell you about CSF examination. CSF examination, I think all of you know, you do the lumbar puncture and then take out the CSF. But I will tell you practically, nobody is going to do the test in the case of subarachnoid hemorrhage. But nobody will do that. This is only for your MCQ and academic purposes. I am going to tell you. What will you initially find? Suppose the patient has just presented to you with the features of subarachnoid hemorrhage, and you put the needle in the subarachnoid space and take out the fluid. How does the fluid will appear? It would be something like, normally the fluid is white. Sorry, not white. Normally the fluid is like a water. Normally the cerebrospinal fluid is like a water. What do you think will happen? There is a subarachnoid bleeding which is happening. Subarachnoid space is the place of CSF also. So how do you think that fluid will come out? It will not be like a water. It would be blood mixed itself. That is what we call it as a bloody tap. This is what is called as a bloody tap. Able to follow this. This is what we call as a bloody tap. That is, blood mixed CSF will be present, because you all know the simple reason: subarachnoid space contains CSF. Very, very simple. And there's a bleeding means you will get a bloody tap. That is what you will see immediately when you do the lumbar puncture. Suppose you do the lumbar puncture like 6 to 12 hours later. Think like this. That means now the patient is having road traffic accident. 12 hours later, you are doing the lumbar puncture. Now here you will not have the bloody tap. No, you will not have a bloody tap. You know what is the color of that CSF you will get? Can anybody comment on this? What is the color of the CSF you will get? It will not be like water. It won't be like bloody tap. It would be something like xanthochromia. It would be something like xanthochromia. Anybody wants to comment on this? Xanthochromia? Any comments on this? Chromia means, I think all of you know, color. What does the xantho refer to? Any idea? Xantho refers to the yellowishness. Now, can anybody explain why you should get yellow color? What is that reflection of? What is it a reflection of? Yellow color is a reflection of bilirubin in the CSF. Yellow color is a reflection of bilirubin in the CSF. Please wait, Dr. Anu, I will explain it. Okay? Yes. Yellow color is a reflection of bilirubin in the CSF. So how do you think bilirubin would have come? Yes, very good. Some of you already answered it. What is that? See, I told you there is blood which is accumulating in the subarachnoid space. And this blood is not something which is going to take part in the circulation, correct? And after some time, what will happen? The RBC will undergo lysis. And when the RBC lysis, you will get hemoglobin. From the heme, you are going to get biliverdin, and then you get bilirubin. I'm not writing fully, I'm just writing the main things. So this bilirubin is the one which contributes to the yellow color present in the CSF. Are you able to understand this point which I'm trying to tell you? So that is what xanthochromia is, a very important characteristic finding noted in case of subarachnoid hemorrhage. This is purely for your MCQ purpose. But again and again, I'm repeatedly telling, we are not going to do lumbar puncture, because remember, whenever you are suspecting a brain injury due to road traffic accident, what will happen? What will happen? There will be something like a mild elevation of intracranial pressure. And I think all of you must have studied lumbar puncture will be contraindicated at the time of raised intracranial pressure. So that is what I was telling you from the beginning itself. We don't actually do lumbar puncture. But for your exam purposes, for your MCQ purposes, just remember, if you do lumbar puncture, immediately after the trauma, you will get a bloody tap. Number one. Second thing, if you do it little later, you will get a yellow color in the CSF, which is what is called xanthochromia. I hope this is clear. Fine. So that's about lumbar puncture analysis, purely for your exam purposes, I'm trying to tell you. Okay. Then this is what I have told you. What is that? A patient is presenting with trauma. The patient is suspected to have subarachnoid hemorrhage. The investigation you are going to do is a non-contrastive without any doubt. Suppose I tell you one more situation. What is that? I don't have a patient with a trauma. But he is presenting with features of subarachnoid hemorrhage. I do the lumbar puncture, not lumbar puncture. I do the CT scan and I confirm it is only subarachnoid hemorrhage. Now, without trauma, what is the condition you will think about? Without trauma, what is the condition you will think about? Without trauma? It could be probably ruptured berry-aneurysm. So don't you think in this particular situation, you should also look for the presence of berry-aneurysm? Don't you think so? If it is a non-traumatic subarachnoid hemorrhage, subarachnoid hemorrhage, you should investigate for berry-aneurysm. That is what I'm trying to tell you. I hope this point is clear. Investigate for berry-aneurysm. Now, if I put the question like this, what is the investigation of choice for berry-aneurysm? What will be your answer? Simple question. What will be the investigation of choice for berry-aneurysm? You are going to look at a structure inside the brain, and that too a structure related to artery. So which investigation I have to do? Anybody? First of all, I have to do MRI. That will be the best way to look at the brain structures. And along with the MRI, I should also look for the artery. So what should be the investigation of choice? It should be MR angiogram. MR angiography. That would be the investigation of choice. MRI combined with angiography, that will very typically tell you about the location of the berry-aneurysm with relation to the brain structures. Okay. I think all of you will agree with me. It's not a very difficult question at all. For berry-aneurysm, this is what you have to remember. Okay. Now have a look at this picture. The first picture we have already discussed. This is nothing but the blood in the subarachnoid hemorrhage or the Sylvian fissure. That's what I already told you. Now this is a picture of angiogram. Okay, can you see the picture of this angiogram? Very typically, can you see these are the arteries which are being depicted, branches of the arteries are being shown. And can you see this dilated structure? This dilated structure is the aneurysm. So, see, if you do the angiogram alone, you will see the berry-aneurysm. That's okay. But if you want to know the exact location of the aneurysm, you should combine the angiogram with MRI also. That is why I have written it is MR angiogram. Okay, MRI with angiogram will be the investigation of choice if you want to look for berry-aneurysms. Is that clear? Okay, very correct. Okay, so that's about some of the important things which I wanted you to know regarding the investigations in case of subarachnoid hemorrhage. Finally, few words about complications of biliary aneurysm. These are all just like one-liner questions. You can just quickly note it. See, vasospasm. See, I told you, it is something which happens between day 3 to day 7. I will tell you what it is. See, what is the point? Artery in the brain circulation has ruptured. So, as a compensatory mechanism, what the body will try to do, the body will try to undergo vasoconstriction to constrict that involved artery. That is what is a normal response, right? Because if you want to control the bleeding, you want to close that blood vessel. So, the body will try to undergo vasoconstriction. That's what I'm writing as vasospasm. Sometimes what happens, the vasospasm becomes so severe that every blood vessel in the brain becomes constricted. Now, what do you think is the problem? If every blood vessel in the brain becomes constricted, what will happen to the blood flowing into the brain? That also will be decreased. Or in other words, this would result in decreased perfusion of the brain. This would result in decreased perfusion of the brain, or the brain can go in for ischemia. This is not at all a good condition, because if this is going to be for a long period of time, it can even result in death of the patient also. So that is why this is a one-liner question, that vasospasm is the most common cause of mortality, that means death, and morbidity, that means difficulties after a subarachnoid hemorrhage. This is an important MCQ question. Please note it. Most common cause of death as well as morbidity, that is problems or complication after SAH, it is always vasospasm. For you to understand this, right? So just make a note of it. It is just a one-liner, nothing much. Just a one-liner question. That's all. Okay, right? So that is number 1, which is vasospasm. Second thing, hydrocephalus. Okay, why do you think hydrocephalus can occur? See, you all know that hydrocephalus is a condition of increased CSF, correct? Increased cerebrospinal fluid. Why do you think it can occur? Very simple. Cerebrospinal fluid is something which is flowing in the subarachnoid space only. And if you have lot of bleeding in the subarachnoid space, don't you think the absorption of CSF will get affected? Because CSF is affected from the subarachnoid space. Here, the subarachnoid space is filled with lot of blood. So what happened? The absorption of the CSF will get affected. So the level of CSF will increase inside the brain, and it will cause hydrocephalus. So I'm good, right? Hydrocephalus can occur, not always, but if it occurs, it is due to decreased absorption of the CSF. It is due to decreased absorption of cerebrospinal fluid. Decreased absorption of CSF. I hope you're able to follow this. Third is re-rupture. This is only for cases of biliary aneurysm. Re-rupture of biliary aneurysm can occur. Not always. These are just some of the names of the complication I'm writing. Around 1 to 2 weeks it can occur. Around 1 to 2 weeks it can occur. Re-rupture of biliary aneurysm can occur. And last is inappropriate ADH release, which is what we call SIADH. SIADH. Okay, I'm not going into the topic details and all. Any pulmonary condition, any neurological condition, if it is severe, there can be inappropriate release of SIADH. And I told you yesterday itself, one of the clue for SIADH when you investigate this patient would be what? Hyponatremia would be present. Do you remember that yesterday I told you? Hyponatremia can be present. That's what I told you. Okay, right? Yes. Very correct, doctor. Okay, very correct. Okay, fine. Are you able to follow this? Yes. Is that clear? Right. So these are the some important complications which you should remember regarding this subarachnoid hemorrhage. But don't forget, the first one is something which is very, very important for you to know. So please know it very correctly. Okay. Vasospasm. Okay. Right. Now, 2 more one-liners I wanted to ask you quickly. What is the most common cranial nerve involved in biliary aneurysm? What is the most common cranial nerve involved in race ICT? This I will put it as a question. You have to tell me later also. What is the most common cranial nerve involved in race ICT? You find out with the reason. I will ask you later. Right now, I'll tell you in biliary aneurysm, what is the most common cranial nerve involved? It is not every case of biliary aneurysm you will have a cranial nerve involvement. It is something like specifically this area. You see here, this is also a part of the circle of Willis on the base of the brain which we are talking about. And can you see in this area, I'm talking about this area. Okay, if biliary aneurysm is present, something like this. Think of this as a biliary aneurysm. If that biliary aneurysm is present in that particular area, it can press on the nerve which is shown in yellow color. Can you see that? Which is shown in the yellow color. What is this nerve? What is the nerve which I'm highlighting now? Oculomotor nerve. So if the biliary aneurysm is present in one of those arteries area, it can press on the oculomotor nerve and it can cause oculomotor nerve palsy. So what is oculomotor nerve? It is nothing but the third cranial nerve. So please remember, as a one-liner question, you can remember most common cranial nerve involved in biliary aneurysm is third cranial nerve. Third cranial nerve. cranial or the oculomotor nerve. That's what. Okay. Right. Very good. Some of you already told me the answer. Very correct. Very correct. Correct. Okay. Others, please try to find out the next question. What is the most common cranial nerve involved in raised laxity along with the reason? Along with the reason. Okay. Fine. Now, finally, we move on to the management of subarachnoid hemorrhage. Remember, subarachnoid hemorrhage is a condition which you cannot completely reverse. It is something which will get slowly resolved. Okay. So, what you should do is mainly about supportive management, which you're going to do for this patient. What you can do? You can take measures to decrease the ICP. ICP means intracranial pressure. That is something which I'm going to discuss in detail shortly. In the upcoming topics, I will discuss how to manage raised ICP. At the time, I will tell you in a detailed way. Then you have to maintain the blood pressure. I told you many patients can have hypertension, right? So you try to maintain the blood pressure in one particular range. Any idea what is the range we maintain? It is 110 to 160 millimeters of mercury. I'm talking about systolic blood pressure in this range. See, it depends on the initial blood pressure of the patient. For example, if the initial blood pressure of the patient was 150 millimeters of mercury, how much do you think I will maintain? I will maintain to the level of 110 millimeters of mercury. If the initial blood pressure of the patient was 200 millimeters of mercury, I would maintain it in the range of 160 millimeters of mercury. Now, a question can come to your mind. Why, if a patient is having 200 millimeters of mercury systolic blood pressure also, why can't I decrease it to 110 or 120? It's a normal range itself. From 200, why can't I decrease to 120? Can anybody answer that? Why can't I decrease it to 120? From 200, why can't I decrease it to 120? Normal range itself. I'm saying from 200, I have to decrease only to 160. Why not 120? See, it's a very simple thing. What is the simple thing? If I decrease so much, okay, if I decrease from 200 to 120, I am decreasing 80 millimeters of mercury, okay, right? And that will even interfere with the perfusion of the brain also. I think all of you know the basic physiology. What is that? If you decrease the blood pressure so much, the amount of blood entering an organ also will be decreased. Think like the brain is going to be affected. When you decrease the blood pressure so much, what can happen? Even the amount of perfusion to the brain also will be decreased. Again, it can promote ischemia of the brain. So that is why you write only one thing. What is that? Sudden lowering. Please write, remember, write this. Sudden lowering of blood pressure will result in ischemia of the brain. Okay. So if you lower it so much, and that too within a short period of time, you can have brain ischemia as well. So that is why, very good. It will aggravate. Very good. Okay. That is why we want to slowly reduce it. That is the point. Okay. Fine. Then what is the third one? You have to decrease the incidence of vasospasm. Decrease the incidence of vasospasm. So to decrease the incidence of vasospasm, what should we give? Very simple. Vasospasm, why are we so much concerned about? Because vasospasm is the one which I told you. It is a cause of mortality and morbidity in case of subarachnoid hemorrhage. So to decrease the vasospasm, you can give a vasodilator. Very simple. So what vasodilator can you give? You can give nimodipine. The commonest vasodilator which is used is a calcium channel blocker only, like nifedipine. It's not nifedipine actually, it's nimodipine, which is useful. Okay, it is nimodipine which is useful. This is an important MCQ question. Which drug can be given to all patients with subarachnoid hemorrhage to decrease the incidence of vasospasm? It is nimodipine. That's what you should remember. Fine. Okay. Finally, suppose I have a patient who is not having a road traffic accident. Instead, he had a berry aneurysm. And then after that, he had a subarachnoid hemorrhage. Okay, right? What I will do, first I will stabilize the patient, do all these things. Then I have to go for the treatment of berry aneurysm also. Because if I leave that particular area intact like that, in future, he can have re-rupture of berry aneurysm also. So, berry aneurysm, if it is detected, you have to treat it. So can you tell me how you can detect this, how you can treat this condition? It's very simple. Think like this as the artery and this is the aneurysm. What I can do is I have to block the connection of this aneurysm with the main artery. Or it is something like I will put something like a coil in that area and will separate that area from the rest of the artery. So what happens when you put a coil in that area, the blood coming into the area will be compromised. So berry aneurysm will automatically shrink. Are you able to follow this? That is one thing I can do. Second thing what I can do is I can put a clip. It is not like the other clip which we are talking about. What we will do is we will put a catheter, something like angiogram. Think like you are doing an angiogram. Angiogram you will always do with the help of a catheter, something like this catheter. Through the catheter, what I will do, I will put a clip, and that clip will lock this area, and again blood supply to that aneurysm will be affected. So the aneurysm will start shrinking. Remember, follow this. This is something which is done with the help of angiogram. Okay, so this is called as angiography directed. Angiography. Okay, angiography directed embolization of the artery. Embolization of the artery, and this embolization of the artery is with the help of coiling or clipping. That's what you have to remember. If you understand the logic, that is enough. What are you doing by this coiling or clipping? We are interrupting the blood flowing into the aneurysm. So aneurysm will automatically shrink. That's all. Very simple concept only. Okay, right. So these are important things which you should remember regarding this subarachnoid hemorrhage. Okay. So subarachnoid hemorrhage, just a quick look. Few important points quickly I'm going to tell you. What is the first one? The first one is it's a very dangerous type and usually associated with trauma. If not associated trauma, it is associated with belly aneurysm. That's what you should remember. Three important features of the subarachnoid hemorrhage are: one is it's a very severe headache called the thunderclap headache. Number two, there will be presence of neck stiffness but without fever. With fever, will tell you it is meningitis. Number three, there will be no other focal neurological problems like no speech problem, no limb problem, nothing like that. Only headache with neck stiffness. That is when you will think about subarachnoid hemorrhage. And the best investigation you can always do for any patient with suspected subarachnoid hemorrhage is non-contrast CT of the brain. That's what you need to remember. For all subarachnoid hemorrhages, you need to manage only supportively, like maintaining the blood pressure, decreasing the vasospasm. That's something which is very important because if you don't control vasospasm, that itself will lead to death in a patient with subarachnoid hemorrhage. And finally, for belly aneurysm, 3 points I told you. Belly aneurysm, the investigation of choice to diagnose is MR angiogram. In belly aneurysm, the commonest cranial nerve involved is third cranial nerve. And finally, treatment of belly aneurysm is an endovascular or angiogram directed procedure, which is coiling or clipping of the aneurysm. That's all. So that is all about subarachnoid hemorrhage, which you should know. Then quickly we will see the other two hemorrhages also. What are the two names I have written? Epidural hemorrhage and one more is subdural hemorrhage. Okay, this I think some of you might have heard about. Not only in your medicine I'm discussing, not only in your surgery classes. I think even in your forensic classes also, you might have heard about these terms: epidural, subdural hemorrhage, and all. They are also has got a lot of importance. First, we'll start with the epidural or extradural hemorrhage. Here again, it is related to trauma. Here again, it is related to trauma. Okay, and epidural. What is the meaning of epidural? Epidural means outside the dura mater. I think all of you know dura, arachnoid, and pia matters like that. Dura is something like the outer covering or the outer part of the meninges, right? And dura mater is something which is closely related to what? Okay, dura mater is something which is closely related to what is the other structure outside the meninges? It is bone. And this condition, epidural hemorrhage, is more closely related to fracture of the bones during trauma. Fracture of the bone during trauma. Any idea what is the most common fracture which is associated with epidural hemorrhage, or which part of the skull? Is it frontal, temporal, parietal, or occipital area? Any idea? Most commonly, it is related to fracture of the temporal bone. This type of hemorrhage usually occurs. Most commonly related to fracture of the temporal bone. And can anyone tell what is the reason for this bleeding? What is the reason for this bleeding? Is it an artery-related bleed or a vein-related bleed? It is artery-related bleed, and it's due to rupture of the branches. Rupture of the branches of middle meningeal artery. Rupture of the branches of middle meningeal artery. Just a second. Sorry, doctor. Okay, sorry for that. Right, it is due to rupture of the branches of middle meningeal artery. Okay, fine. Now, what do you think would be the features of this particular condition? Okay, what is berry aneurysm? See, I have already discussed berry aneurysm previously in subarachnoid hemorrhage. I have already discussed. Okay, right. So, what are the features of this epidural hemorrhage or extradural hemorrhage? If you don't have spaces, you can write in the next page also. Okay, one of the important feature obviously would be headache. Without any doubt, it would be headache. Sudden headache only. Just like any other hemorrhage, you are expecting headache here also. But is there any other characteristic finding associated with epidural hemorrhage? That is what I told you. It is something which has got importance in your forensic cases also. Okay, I think even in some of the movies you might have heard about this. Okay, you might not have heard the name actually, but you might have heard about the presentation like this. What is it? After a trauma, the patient becomes unconscious. After a trauma, the patient becomes unconscious, and after reaching the hospital, he becomes conscious again. And even after some time, he again goes into unconsciousness, and then he may die also. What is this called? Unconsciousness, then conscious, then again become unconscious, and can even result in death also. What is that? Very good. That is what we call it as a lucid interval, which is supposed to be very, very characteristic association of epidural or extradural hemorrhage. Okay, and the lucid interval follows a pattern, something like this. What is that? Initially, following a trauma, the patient would be unconscious. Patient would be unconscious. And after that, he becomes conscious after some time. These times are not very defined, like 30 minutes, 1 hour at all. It's just like few minutes like that. And later again, he goes into unconsciousness. Okay, right. He becomes unconscious. This typical sequence of consciousness in between two periods of unconsciousness is actually what we call it as a lucid interval. Any of you explain why this is happening? Why the initial unconsciousness following a trauma? It is due to something like shock of the trauma itself. What do you call it as concussion? It is due to concussion. It is due to concussion, the patient is having initial unconsciousness. Suddenly after a trauma, the brain goes into a state of shock, right? That will result in, that is what we call concussion, and that results in unconsciousness. Later, he becomes consciousness. Once the patient recovers from the concussion, he becomes conscious. Then why again he goes into unconsciousness? What happens once the edema starts developing? There will be progressive increase in the intracranial pressure. There will be progressive increase in the intracranial pressure, which again makes the patient to become unconscious, which again makes the patient to become unconscious. Are you able to follow this? So that is what you have to remember. Lucid interval. Okay, this is a very, very characteristic finding of epidural hemorrhage. If you don't treat the patient in the second time of unconsciousness also, progressive intracranial pressure can even lead on to death of that patient also. That is what you should remember. This lucid interval is something which is very important. And I think in your forensic classes and all, they will teach you so much that lucid interval has got important medical legal consequences also. Okay, so please make a note of this, and later in your forensic classes, you will learn more about this. Lucid interval is very, very important for your exams. Okay, right. And again, how are you going to evaluate this patient? This is also a patient with a trauma who has developed this problem. So what should be the imaging modality of choice? And I told you this already. What is that? You have to use NCCT, non-contrast CT. Okay, you have to use non-contrast CT. Now look at this non-contrast CT. Look at it like two separate pictures. I put them together actually. Only this side is for epidural hemorrhage. Only this side is for epidural hemorrhage. Any comments on that thing? Can you see that this is the epidural hemorrhage? Can you see? It is white in color. That's what we are talking about as a hemorrhage. And how does the shape appear like? Its shape appears like a lemon. That's what is called as a lemon-shaped swelling. Any other name, doctors? Any other name? Lemon-shaped. Anything else? It's also called lens-shaped, right? Lenticular swelling. And it is also both sides convex. What is the normal lens shape we say? Biconvex, right? So this is also biconvex swelling. This is also biconvex swelling. Able to follow this. This is a very characteristic swelling which we should know about. Okay, biconvex, lens shaped or lemon shaped like that. Can anybody tell why this is? Yeah, it's something like that of an Italy, right? Correct. That is true. Now, why this is like a why this is like this shape? Can anybody comment on this? Why it is something like this, localized only? Do you think dura is only to that particular area? Suppose think of this area as a temporal area. What I'm saying, it is only located to the temporal area. Why? Why not it is going to this area and all? Why it is only located to the temporal area? Very, very simple. You all know that temporal bone, parietal bone, frontal bone, they're all separated by what? They're all separated by sutures. I think all of you know about this. They're all separated by sutures. So think of a swelling or think of a bleeding which started in the temporal area. Can it cross the suture and go to the other areas? Impossible, because it is something which is like a limitation or separation between the different skull bones. So the reason is very, very simple. Why it is not a big swelling? The reason is because it is limited by sutures. Very, very simple. It is limited by sutures. Please understand this. Epidural is a big space, but the bleeding will not extend to other areas. Why? Because it will always be separated or limited by sutures. I hope you're able to understand this. Clear? Fine. Okay. All right. So that is why the shape looks like that of a lemon shape or a lenticular shape or a biconvex shape. Is that clear? Okay. Fine. Now, finally, what do you think is the treatment of this condition? Remember, this is a localized swelling. So what I will do is, it will be done by a neurosurgeon. What they will do, they will make a small opening or small hole in the skull area. Think like this, temporal part of the skull. They will make a hole, and through that they will access the epidural space and take out all the blood. Any name for this procedure? Any name for this procedure? It is called craniotomy. It is called as a craniotomy. It is called as craniotomy. Make a note of it. What is the simple meaning of this? It's making a hole in the skull and drain out the fluid. Okay, to drain the blood. That is what is called craniotomy. That word is important, called as otomy. Whenever you use the word otomy, it is something like a hole. That's all. Dr. Burhole, I will come to a little later. That is in the next situation. I will tell you that this is something like a simple procedure only called craniotomy. I'll just take the picture here. See here, this picture. Okay. Oh, sorry, that picture is missing. Just a minute. Okay, I'll just take that picture during the break time and I will just put it up. Okay, what is that craniotomy? I'll just put it up in an explanation. Okay, fine. So that is about this epidural hemorrhage, which I want you to remember. Now we move on to the next one. What is the next one? Subdural hemorrhage. What is the meaning of subdural? It is below the dura. That means what? Dura mater and arachnoid mater, it is present. Okay, that is what is called subdural space. And subdural hemorrhage, please remember this, it can be associated with the head trauma also, wherein it will have a sudden presentation or an acute presentation. That's what we call acute subdural hemorrhage. That is the subdural hemorrhage which is associated with trauma. But the common variety of subdural hemorrhage is something which is more like associated with repeated small trauma to the skull. Okay, repeated trauma to the skull. See, initial trauma I'm talking about is something like RT, road traffic accident, which will be an acute presentation. The next condition which I'm going to talk about is something like not a sudden presentation, it is repeated trauma to the skull. Like for example, repeated fall, which you typically encounter in elderly persons or in a very small children. Think like the toddlers and all. When they're learning to walk, when they're learning to run and all, they repeatedly fall, right? I think you can imagine that situation. But common thing for your exams to remember is elderly patients. Okay? I think all of you know that elderly patients also have difficulty in walking, especially in the washrooms and all. They slip off, right? And they can have repeated trauma to the skull also. Okay, that is how they present. What happens every time they have a trauma, small amount of blood will start accumulating, and this is what we call it as a chronic SDH. Chronic SDH. Can you think of any other situation also where it is more like a profession? The patient gets exposed to repeated trauma to the skull. Any other profession also, or it's like that sports person who's getting exposed to repeated trauma to the skull. What is that? Yes, of course, boxers. Boxers also, they are prone for developing chronic subdural hemorrhage, repeated this thing, right? Okay, so these are the group of persons who are going to develop subdural hemorrhage. One is the boxers, elderly person, or very small children like the toddlers also. Due to repeated falls, they can have this particular type of SDH which is happening. Now, anybody wants to comment? What is the reason for subdural hemorrhage? Sorry, reason I have told you. What is the source of bleeding? What is the source of bleeding? It's not the reason, I'm sorry. What is the source of bleeding? Is it an artery or the vein? For epidural hemorrhage, I told you it is the middle meningeal artery. Can you tell me for the subdural hemorrhage? It is something related to brain. It is something related to, something related to the veins. Which veins? It is due to rupture of the bridging cortical veins. Rupture of the bridging cortical veins. Don't forget this. Okay, it is due to rupture of the bridging cortical veins. Okay, bridging cortical veins. Okay, now how do the patient present with? They present with slowly progressive headache. They have slowly progressive headache. It is not like all of a sudden they will present to the emergency room at all. They will just come to the OP and they will say that, doctor, for the past few months, I'm having gradually increasing headache. That is how they typically present. Slow, progressive increase in the headache. Along with that, they also have some sort of confusional state. Confusional state. It's something like they tend to mess up things. Like they tell you slightly differently. Like they'll always have some sort of confusion in their mind. Okay, something like that, right? So in addition to headache, they can also have confusional state. In these patients also, you are going to evaluate with NCCT only, non-contrast CT only. And what is the typical swelling you are seeing? Can you see this area? This is the area of subdural hemorrhage. Can you see that? First of all, it is like a big swelling compared to the previous one. Can you see that? It is not a localized, it's a diffuse swelling. And what is the shape? Looking like that of a banana. Okay, it is called as a banana shape swelling. Any other names we can use? Concavo, convex. One side is concave, another side is convex. So the concavo, convex swelling. How does it look like? It looks like a half moon shape. What do you call that? Semi-lunar shape also. So many names are actually there. It's also called crescent shape and all. Common ones you can remember: semi-lunar shape, there's a half moon shape or a banana shape like that. All those things you can remember. Characteristic for subdural hemorrhage. Okay, subdural hemorrhage. Very classical. Again, non-contrastive only. I'm going to take. Okay, right. This is what is the finding which I'm going to look at. Finally, what is the treatment for this condition? Remember, I cannot put just one hole and take out everything because it's a big swelling, correct? It's a big swelling. So what I have to do is I have to do multiple holes in that area. This is what we call it as a burr hole surgery. This is called as a burr hole surgery, which you have to remember. This is usually done for chronic subdural hemorrhage, chronic SDH, chronic subdural hemorrhage. You have to do this burr hole surgery. Okay. Now, if you have a trauma patient, that means acute SDH, what you have to remember, what you have to do is something like you have to cut actually a part of the skull itself and take out the blood from that area. This is called as decompressive craniectomy. It is called as decompressive craniectomy. I hope you can follow the wordings. Cranio means skull, ectomy means removal. So what I'm trying to tell you is something like removal of a part of a skull itself. Removal of a part of a skull itself. That is what is called craniectomy, decompressive craniectomy. Okay, just make a note of it, or decompressive craniectomy. Are you able to understand this? So, if you have an elderly patient who is presenting with repeated episodes of headache and you are suspecting and you're confirmed that it is subdural hemorrhage, then it's a chronic SDH. For that, the treatment of choice is burr hole. Burr hole is something like this. What is that? You create multiple holes in the skull. This area, this area, this area, this area, this area, like that. Multiple holes in the skull you put up, and every area you keep removing certain amount of blood. That is what is called burr hole surgery. It's actually a very long procedure. One of my colleagues who is a neurosurgeon used to tell me like this: if they start the surgery in the morning, even till evening or late night also, that procedure will go on. It is like a lengthy procedure. That is what it's a very long procedure, burr hole surgery. And if it is an acute situation, you don't have so much of time to remove small amount of blood. What you will do, you will actually remove a portion of the skull itself, which is what is called craniectomy, and then from that removed area, underneath will be the meninges area, you can take out the blood. That's all. That is called decompressive craniectomy. Okay, fine. So please make a note of this. For EDH, the treatment will be craniotomy, and for SDH, the treatment will be craniectomy. Okay, please make a note of it. I will just try to, take up the pictures. Okay, I'm going to give the break now. I'll just take up the pictures, and after the break, I will put up the pictures and try to explain it in a visual way. Okay, so we will have the break now. During the break time, you just have a look at this question and try to, think about it. Okay, right? I'm not going to tell the answer now. Now we are going to have the break. Have a look at this question. Try to think about if you have anything in your mind or you can come across anything. Do let me know after the break. Okay. Now the time is 11:40. We'll have a 15 minutes break, and after that I will start. Is that fine? Okay, right. So we'll be having the break now, and I'll start after 15-20 minutes. Okay, right. Okay. Okay. So we'll get started now. Okay, so yes. So I hope we'll get started now. So the audio and video is clear. Okay, so we will start with the next topic. Yeah. So I hope everything is okay. Right. Okay. So now, before I get started with the question, look at this particular one which I had asked you to see. Not this one, sorry, the other question I am going to discuss. This one is like a picture which is depicting that craniectomy. Okay, it is depicting the craniectomy. Can you see that? A lot of small holes are being put up. This is what we call it as a burr hole. And once you are doing that burr hole, okay, it creates this is burr hole surgery, okay, which I have put up. One more thing is you are removing this part of the bone itself. That is what is called craniectomy. Okay, now if you just remove only one, not remove, if you just put only one hole like this in one particular area, then it is called craniotomy. Okay, craniotomy. Only one hole in one area, it is called craniotomy. When you put multiple holes, it is called burr hole surgery. When you take out a part of the bone itself, it is called craniectomy. I told you craniotomy is for EDH, burr hole surgery and craniectomy is for SDH. That is what I told you just before concluding the previous session. Okay, right. Now this was a question which I asked for. Okay, and I am glad to know that some of you have already messaged me the answer. It is very good, and on your part to message the answers. And also, I am happy that classes are helping in your preparations. The thing which I wanted to tell is like medicine is definitely a vast subject. It is much more than what we are learning in the classes here. But still, from the exam point of view and in the limited time which you have for your preparation, this is the maximum which you can do also, and that is what I am focusing on. I am focusing mainly on the areas or the topics which are asked in your MCQ exams, and I'm also trying to add clinical relevance to all of those particular topics, like how you can get that patient presenting to you in the hospital or in the OP like that. Okay, and if you can also study in the same way, I think it will be easier for you to solve those type of questions, because once you finish the classes, read the subject, and then when you solve those MCQs, you will understand some of the points which are asked in the questions are something which I have highlighted. Okay, this is the characteristic feature like that. And whenever you read, not only medicine, any clinical subject for that matter, whenever you read, please always give importance to the clinical aspect, because that is what is the pattern of question nowadays being asked in the exam, where emphasis is given to clinical scenarios. Like you are seeing this patient in the hospital, how are you going to analyze this particular patient's finding? How are you going to give a diagnosis to this particular features present in the question? Okay, something like that, right? So all these things will definitely play a part, not only for this MCQ exam, even in future when you become clinicians. This is how exactly you will think about it, right? It is not that every patient will have a straightforward diagnosis whenever he is presenting to you. You will put together a combination of examination findings, clinical history, investigation, and then only you make the diagnosis. And that is what exactly we are also trying to emulate in these classes. Okay, fine. So here also I am seeing so many answers. Very good. Most of you have come up with the answer. What is the situation? It's a patient admitted to the ICU following a road traffic accident. He is in a comatose stage, means he is not active at all. He is in a coma stage. And non-contrast CT reveals no significant finding. This is what it is. Okay, because whenever a patient is in an unconscious state or coma state following road traffic accident, what are you expecting in the non-contrast CT? You are expecting a bleeding. Okay, but you are not seeing any of that bleed, like a subarachnoid bleed or a subdural bleed or a extradural bleed. You're not seeing any type of bleed in the non-contrast. That is what's written. NCCT reveals no significant findings. What is the probable diagnosis? I'm glad that many of you have answered this very, very clearly. It is a case of DAI. Okay, DAI. Very good. It's called diffuse axonal injury. Okay, diffuse axonal injury. First, to write the name, then I will explain the condition, and then I will tell you why non-contrast CT was not having any findings. Okay, I will tell you that. Okay, see, this is a condition which is something you might have heard in your forensic classes. Okay, if you have attended or you have completed those classes before, you might have heard something related to this. What is that? It usually occurs in the setting of a high-speed road traffic accident. Think like this. A person is cruising in his car in a highway, okay, like around 130, 120 kilometers like that per hour. He is cruising at a very high speed, okay, and suddenly something crosses in front, okay. You think like maybe something like an animal crossing in front or something like that. There's an obstacle in front, and he applies a sudden brake. You think like this. He applies a sudden brake. What do you think will happen? Of course, braking will happen, but at the same time, there's a shaking of the body, correct? And look at like this, something like the shaking of the head, okay, something like shaking of the head. What is that? It is something like the head will go back and then come forward, suddenly going back and coming forward like this. Something like what? Something like a, I think you might have heard about this name in your forensic classes. What is that? The name is called something like a whiplash. Okay, something like a whiplash. I hope you can understand what I'm talking about. Something like a whiplash suddenly goes forward and suddenly goes backward. Something like this. This is what it is. Can you see that? Going forward and coming back and like a whiplash. Okay, this is what we call it as a whiplash injury, or which is characterized by acceleration followed by deceleration. Sudden acceleration followed by sudden deceleration injury. That is what we call it. And because of the sudden acceleration and deceleration, what is going to happen is, along with that, of course, you will also have this rotational head movement also. You will also have rotational head movements also. You will also have rotational head movements. Now, all these together, that means forward, backward movement, rotational movement, everything which is happening in a quick span of time will result in something like this. Again, I'll go back to the picture. Can you see what is happening? Can you see what is happening in this particular area? What is the problem which is happening? This is the gray matter. Can you see that? This is the gray matter. I'm just writing in G like that. This is the gray matter, and this will be the white matter. And can you see what happened at the gray-white matter junction? There will be something like a stretching and a pulling effect which will happen. What is there at the gray-white matter junction? Look at this bigger picture. What is that? This is the gray matter area. This is the white matter area. Can you see all these are the nerve axons which we are talking about? Can we see that? This is the cell body. These are the dendrites, axonal sheath and all which is there. What what is going to happen? It is going to create something like a pulling effect or a stretching effect. And this pulling and stretching will create tears in the axon. It will actually create tears in the axon. Okay, it will actually cause tearing effect in the axon. Can you see that this area is the area where you are having this tearing effect? Are you able to understand this? Okay, right? So what happened? The connection inside the axon will be cut. Okay, the connection inside the axon will be cut. And I think all of you know axons or the nerves of the area where conduction of nerve impulses is going to happen. So whenever there is a lot of cutting of the axons, there is no transmission of nerve impulses itself. That is why the patient ends up in the coma state. Are you able to follow? That is why the patient ends up in the coma state. This is due to small tears in the axon, which is happening. Of course, in all these areas of tear, you will have a bleeding, but it will be something like a point bleed. Okay, something like a pinpoint bleed like that. Small dot type of bleeding, something like dot type of bleeding. Okay, and that is what is represented in this particular picture also. Can you see that? Small dots of bleeding like this. And do you think you will be able to see this small dotted bleeding on a CT? You will not be able to see all those dotted bleeds on a CT. That is why in this particular situation, if you take CT, it would be appearing to be absolutely normal. I hope you can follow what I'm trying to tell you. Or in other words, this is what we call as the micro bleeds. This is called as micro bleeds. Some of you are answering as punctate bleeds, small pointed bleeds like that, which can never be seen on a CT. That is why CT appears to be very normal in this particular situation. I hope all of you are able to understand this. So let me just try to put it up in words, whatever I have discussed. What is the situation? It's a high-speed road traffic accident, something like a whiplash, usually like forward and backward movement suddenly, along with the rotational movement of the head. This will result in pulling plus stretching of the axons. And whenever there is pulling and stretching of the axon, this will be followed by tears in the axon, tears in the axon. But this tears will result in bleed. But what is the type of bleeding you will get? You will get only small bleeds, which I'm going to write it as punctate bleeds or micro bleeds. That is the word which I'm using. And this micro bleeds cannot be detected on CT. Cannot be detected on a CT. Very important point. Cannot be detected on a CT. Number 2 point which I want you to remember is because of tearing of the axon, there will be no nerve impulse conduction. There will be no nerve impulse conduction because the axon has become teared. Whenever there is no nerve impulse conduction, do you think the patient is going to be active? He's not at all going to be active. He will not even have any consciousness also. That is why the patient ends up in the coma stage. That is why the patient ends up in the coma stage. So please have this picture in your mind. Whenever you have a patient who following a road traffic accident becomes comatose, but CT does not pick up any finding, think about this important problem of diffuse axonal injury. And please remember, among all the road traffic accident cases and all the types of bleeding which we have discussed, diffuse axonal injury has the worst outcome. Many times what happens? The patient will not even come out of this particular coma stage itself. He will remain in the coma for a very long time and he will die also. This is supposed to be the most dangerous type of this intracranial bleeding, which is microbleeding, okay, right? Called as a DAI or diffuse axonal damage. Because I have, see, it is not only one area which is damaged. Can you see that in this particular picture itself? All these areas, can you see that all these areas will be damaged continuously, all these areas, or even on the other side also that will be damaged. That is what's called diffuse axonal damage. And this patient is very unlikely to recover. Okay, we may try to manage symptomatically this patient, but most of these patients will not even recover also. That's why I have written this has got the worst outcome among the different types of condition which we have discussed here. So now, can anybody tell me how can I investigate this particular patient? What should be the investigation to find out the small bleeds in the axon and all? What do you think will be the best investigation in this particular situation? I cannot do a CT because anyway CT is going to be normal. So what is the investigation of choice in this particular situation? It's a small damage inside the brain. What is the best investigation here would be? Very correct. The investigation here, it is going to be MRI brain. That will be the investigation of choice. This is an important MCQ question. MRI brain will be the investigation of choice. Please don't forget this. This is the investigation of choice. Okay, MRI brain will be the investigation of choice. Are you able to follow this, right? Okay, fine. Is there any lag? Is there any difficulties? Okay, fine. Okay, as I told you, there is some lag between the time I'm speaking and when you are hearing actually. So it is fine. That's okay. But okay, right. Keep following. MRI will be the investigation of choice. Okay, very correct. Okay, now can anybody tell me which is the most common site where actually this bleeding is occurring. Which part of the brain it is usually affected? Which part of the brain is usually affected? It is the frontotemporal area which is affected. Frontotemporal area which is affected. Okay, and if they ask you which is the commonest site, okay, which is the commonest site? Okay, it is frontotemporal area, but inside the brain, if they ask you, please answer as white matter. It is actually the white matter area near to the gray-white junction. Near to gray-white junction. Okay, near to the gray-white matter junction is where actually the bleeding is happening. Okay, so please have a note of this. This is important. Okay, it's something near to the gray-white matter junction, but exact location will be in the white matter. Can you see that in the picture also I will just show? It is in the area of white matter. Can you see that? It's in the area of white matter only, near to the gray-white junction. Remember, follow this, okay? Right. So these are the things which I want you to remember regarding this particular condition of diffuse axonal injury or diffuse axonal damage. Such an important condition where CT is normal, but the patient is in the coma state. Okay, keep this in mind. Okay, fine. So that is about this one. We will move on to the next one. We will move on to the next one. The next topic is something related to how do you manage a patient with raised ICP? Because in almost all type of road traffic accident cases, you invariably will have raised ICP, and part of management will be related to how do you manage that raised ICP. Okay, so ICP, all are the same. ICP means intracranial tension. ICP means intracranial pressure. All are the same only. Before we go on to the management, let us just quickly look at what are the features of raised ICP. I'm talking about adult. What are the features of raised ICP you can expect? Anybody wants to comment on this? What are the features of raised ICP? What are the features of raised ICP? Any comments? What are the features of raised ICP? Any idea? What are the features of raised ICP? Okay, first of all, these patients can have headache. Okay, correct. These patients can have definitely headache. Yes. What type of headache? What type of headache? Important is that it is in the back side of the head, occipital headache, and also they can have headache in the morning time. Headache in the morning time. It is usually described like this: the patient wakes up with a headache, and that headache wakes the patient from sleep, something like that. Because most of the headache you will remember or you can understand that they occur in the evening time. As the day passes, in the evening time, they will have a headache. That is what usually, right? In the evening time, they have a headache. But this raised ICP headache is something which is very characteristic that in the early morning, the patient will have a headache. Okay, very correct. Okay, headache, especially in the occipital region. Very good. Other things are also correct. Next one would be regarding vomiting. And this vomiting is also occurring in the early morning. And this vomiting is something which is very forceful vomiting, or what we also call projectile vomiting. We can also call this as the projectile vomiting. And when you do the ophthalmoscopy, that is the eye, the patient may complain of blurring of the vision. But if you look at the eye, what you will see, the optic nerve area, there will be blurring of the optic disc margin. What do you call this? Very good. It is called papilledema. It is called papilledema. Okay. Clinically, the patient will tell you that I have blurring of the vision. Blurring of the vision. But if you look at with ophthalmoscopy, you will see this blurring of the disc margin, which is what we call it as a papilloma. These are the characteristic features of raised ICT, which you can get in an adult patient. Okay, that's what you should know about. Then, okay, I asked you this question even before the break also. What is that? Which is the most common cranial nerve to be involved in the patient who is having raised ICT? Some of you already messaged me that correct one. Some of you have told me now. Which is the most common cranial nerve to be involved in a patient with raised ICT? Very good. It is the abducens nerve or cranial nerve number 6. Okay, sixth cranial nerve. Okay, and I think some of you have already told me the reason also. What is the reason? Very correct. What is the reason? The reason is that it has got the longest intracranial course. Very, very correct. Okay, it has got the longest intracranial course. Okay, that's a very correct one. Cranial nerve 6, abducens nerve. It has got the longest intracranial course. And I think all of you know, if the cranial nerve 6 is involved, which muscle is going to be affected? Lateral rectus. Very good. Lateral rectus is going to be affected. So when lateral rectus is affected, patient cannot look at it at the sides. Okay, his lateral vision will be affected. Very, very simple. Okay, right? So this is what you need to know about features of raised ICT. Now going to the topic proper. Okay, before we go to the topic proper, we should know something called Cushing's triad, which occurs in the case of not every case of raised ICT, only in severe cases of raised ICT, you will get something called Cushing's triad. And if you know what is this Cushing's triad, it is basically 3 set of features which occurs in a patient who is having raised ICT. Not every time, I'm saying not every patient with raised ICT will have the features. In severe cases, suppose you don't treat raised ICT, patient goes in for very high levels of intracranial tension, then he can have this manifestation. What are the manifestations he can have? Number one is hypertension. Blood pressure would be increased. Hypertension, number one. Anything else? Number two, heart rate. What happened to the heart rate? Decreased. Very good. Bradycardia. Bradycardia. Number two would be bradycardia. Number three will be an abnormal form of breathing. Okay. Number three would be something like an abnormal form of breathing called Cheyne-Stokes breathing. Called as Cheyne-Stokes breathing. Called as Cheyne-Stokes breathing. Just a minute. Okay. Yes. Cheyne-Stokes breathing. Anybody wants to comment on this Cheyne-Stokes breathing? Any idea? Comment on this. Just a minute. Okay, you can just let me know in the comment. I'm just checking one thing. Okay, right. So can we comment on what is this Cheyne-Stokes breathing? Cheyne-Stokes breathing is something like a very abnormal type of breathing where patient can have three phases. What is that? See, think like this. The normal breathing would be something like this pattern. This is a normal breathing pattern. Think like this. Normally, each and every one of us have this type of breathing pattern. In Cheyne-Stokes breathing, what is going to happen is patient will be having initially something like this. What is that? Fast and a deep breathing. What do you call that? Hyperpnea. Hyperpnea. Fast and a deep breathing. Then he will have a slow breathing like this. Hypopnea. Finally ending with no breathing for a short time. What do you call that? Okay, hypopnea. Okay, hypopnea. Finally ending in no breathing. What do you call that? Apnea. This is what we actually call it as the three phases of the Cheyne-Stokes breathing. Fast breathing, slow breathing, then no breathing. Okay, right? This will go on like a cycle. Fast, slow, no breathing. Fast breathing, slow breathing, no breathing. Something like a cycle, it will go on like this. This is actually what we call it as a Cheyne-Stokes breathing. It's an abnormal type of breathing noted in a patient with raised ICP. Okay, that is actually a part of Cushing's triad. Okay, Cushing's triad, when it will be seen? It will be seen in cases of raised intracranial pressure. Not every case, but in a severe case of raised ICP, you will have this feature. Now, let me try to explain this Cushing's triad. Okay, how the features are going to develop. And I'm going to explain it with the formula, which in your physiology classes, they are going to teach you something called MAP minus ICT is equal to CPP. Any idea what is this? Any idea what are the terms? ICT is, of course, intracranial tension. What is this MAP refers to? MAP refers to the mean arterial pressure. MAP refers to the mean arterial pressure. ICT is intracranial pressure. What about CPP? Cerebral perfusion pressure. Cerebral perfusion pressure. Cerebral perfusion pressure. See, what I'm trying to tell is how much a brain is going to be perfused. How much a brain is going to be perfused depends on the differences between the arterial pressure as well as the intracranial pressure. See, for every organ, what do we say? Blood pressure will determine the amount of blood entering into that organ. That is what we generally say, right? But brain is a special area where not only blood pressure, we also need to have the influence of intracranial pressure also, which will influence the perfusion of the brain. That is what I'm trying to tell you. MAP minus ICT is what we call CPP, or the cerebral perfusion pressure. Now you think about the situation of raised ICT. You think about the situation of raised ICT. In raised ICT, what is happening? Intracranial tension is increased. Okay, sorry, that's raised ICT, intracranial tension is increased. Now, when intracranial tension increases, there is a possibility that the cerebral perfusion pressure will decrease, or the brain will go in for ischemia. Correct? So, body will not allow this to happen. What the body will try to do? Body will try to maintain the cerebral perfusion pressure in the normal range. How can it do so? Only by increasing the mean arterial pressure also. Because only if the mean arterial pressure increases, the difference will become normal and the perfusion will also remain normal. I hope you're able to understand this. That is why the raised ICT directly leads on to hypertension. Hypertension. Okay, why hypertension? Hypertension is an attempt to keep the arterial pressure high in order to maintain the cerebral perfusion. I'm going to write hypertension is being present as a feature to maintain the cerebral perfusion. I hope you're able to follow this. This is to maintain the cerebral perfusion. Are you able to understand this? This is to maintain the cerebral perfusion only. The hypertension occurs. Okay. Now I'm going to explain the other findings. Whenever there is very high levels of blood pressure, what do you think will happen? It will activate something called as baroreceptors. Have you heard about this baroreceptors? Baroreceptors. In physiology, you will be learning baroreceptors. They are present in the area where the carotid artery is dividing into the internal and external carotid arteries. Main carotid artery divides into internal and external carotid arteries. Any of you know what is that area called? The area of the baroreceptors, or the area where the carotid artery divides. We call that area as the area of carotid body. Carotid body. carotid body is the one which contains all these vasoreceptors. They will get activated whenever the blood pressure increases. Think like this. This is the physiology. Okay, they will get activated whenever the blood pressure increases to a high range. And vasoreceptors, when they get activated, what is the nerve which is lying in close relation to the carotid body? Anybody wants to comment on this? Can anybody tell me what is the nerve which is lying in close relation to the carotid body? Carotid artery, carotid body, and what is the nerve which lies in close relation to that? It is the vagal nerve. Okay, it is a vagal nerve. This would cause vagal nerve stimulation. Vagal nerve stimulation. And now you can tell me, when the vagal nerve gets stimulated, what would be the effect on the heart? What would be the effect on the heart? It would cause bradycardia, decrease the heart rate. Correct? That is why bradycardia is a feature of this particular condition. That is why the bradycardia is a feature of this particular condition. Okay. And the reason for Cheney-Stokes breathing is directly raised ICP, causing pressure on the, all of you know, in the brain there is a respiratory center. Due to pressure on the respiratory center of the brain only, there is a abnormal type of breathing which is produced. I will write that also. Raised ICT will cause pressure. It will cause pressure on the respiratory center of the brain. Pressure on the respiratory center of the brain. And this pressure on the respiratory center of the brain will result in an abnormal pattern of breathing, what I have put up in the picture as Cheney-Stokes breathing. So I have tried to tell you the manifestations in a logical way of understanding. Why hypertension, why bradycardia, and also why Cheney-Stokes breathing. So these three features, these hypertension, bradycardia, and Cheney-Stokes breathing, these three features are what we call it as a triad of Cushing's. Okay, and please remember, Cushing's triad is not seen in every case of ICT. It is only in very severe cases of raised ICT, you will get these features. Okay, so please have this in mind. These are all important manifestations. Okay, correct. These are all important manifestations of this particular raised ICT features. The usual manifestations are three only: headache, vomiting, and papillary edema. But in severe cases, you also get the Cushing's triad. I hope you're able to follow this. Able to follow this? Okay, yes. These are the manifestations of raised ICT. Now we move to the topic proper. How do you manage a patient with raised ICT? What are the important things which we can do in the treatment part? Okay. First thing, look at the position. Look at the position of the patient, which I have put up in this picture. This is the position of the patient. When you go to the ICUs, I'm talking about neurosurgery ICUs and all. Like for example, post-operative ward, neurosurgery ICU, post-operative, after neurosurgery and all. You will see that the patient will be put up in this position where you can see the head of the patient or the head end of the patient is elevated. Head end of the patient is elevated. Can you see that? Head end elevation. Not so much of an elevation, but something like minimal elevation, like up to 30 degrees, there will be elevation. Any of you know what is the name of this position called? What do you know about the name of this position? Any of you know about the name of this position? Where the head end of the patient is elevated. I think all of you might have heard about the other one, opposite. What is that? Leg end is elevated. What do you call that position? Leg end is elevated. You call it as Trendelenburg position. This is opposite of the Trendelenburg. So people call this as a reverse Trendelenburg position. This is what is called a reverse Trendelenburg position. Okay, very correct. This is called as a reverse Trendelenburg position. Please don't forget this. This is called as a reverse Trendelenburg position. Okay, please keep a note of this. This is important. Okay, this is one thing which we can do for the patient whenever he's having raised ICT. Then drugs. Okay, this is very important. I'm putting a star because so many questions have been asked from this particular section. What are the drugs which can decrease the levels of intracranial pressure? One, of course, would be a diuretic. But which diuretic you should use? That is the question. Which diuretic should you use? You have to use not the usual furosemide. No. What type of diuretic you have to use? You have to use an osmotic diuretic. Very important. Osmotic diuretic. Normal diuretic and all will not work. Osmotic diuretic, what they will do? They will imbibe the water and they will get excreted. That's all. Okay, that is what is very helpful in this situation of this thing. Any idea what is the example of this osmotic diuretic? It's a mannitol. It is mannitol. Osmotic diuretic. Typical example is mannitol. Okay, don't forget this. That can be helpful. Any other group of drugs which can be helpful? Okay, you might have heard about. Yes, very good. You might have heard about saline, normal saline. What does normal saline contain? I'm not writing as a treatment. I'm just asking you a question. You don't need to write this. What does normal saline contain? Sodium and chloride. And if you have seen the tonicity of the saline which is written, they would have written like this: 0.9%. Have you noticed that? It's a normal percentage of sodium in that normal saline. We call it. Okay, this is not a diuretic and all. This is not helpful in raised ICT. In raised ICT, what you will use is something called hypertonic saline. Hypertonic saline. Any idea what is this hypertonic? What is the percentage? It is 3% saline. 3% saline. Okay, so think like this. What is the role of this hypertonic saline? What is the role of this hypertonic saline? Hypertonic means so much of sodium is present. You think like this. So much of sodium is present. I think all of you know, whenever high sodium is present, it will always imbibe water also with it. I think all of you have heard about that in physiology classes. Sodium always combines with the water. Always will try to imbibe water. So you think like this. If you give hypertonic saline, it goes into the brain. Think like this. And in the brain, it imbibes water. It imbibes water. What do you call that process? Nothing but osmosis. It will imbibe the water by osmosis. And when it imbibes the water, what will happen to the amount of edema in the brain? Cerebral edema. It will decrease. This will decrease the cerebral edema. Decrease the cerebral edema. And this will result in decreased intracranial tension also. I hope you're able to follow this. Okay, decreased intracranial tension and decreasing the cerebral edema. I hope you're able to follow this. Clear? Okay, so that will be the hypertonic saline. Okay, that will be the hypertonic saline. The reason is why we are using high amount of saline, because it will imbibe the water and will decrease the edema. That is what. So basically, the two drugs which I have told act by the process of osmotic. One is the osmotic diuretic mannitol. Another one is imbibing water or osmosis, which is hypertonic saline. I hope you're able to follow this. Okay, these are the drugs which we can use. Now turn the pages and move to the next slide. Suppose you are putting the patient in a ventilator. Imagine most of the patients, including the road traffic accident patients and all, they're severely damaged. We will put them in ventilator. What you can do is you can do hyperventilation. What is the meaning of hyperventilation? Hyperventilation is too fast ventilation. What we will do, very simple. Suppose the patient is connected to the mechanical ventilator. In the ventilator, we will increase the respiratory rate. See, the normal rate we will keep around 16 to 20. Here, what I will do for a short period of time, instead of keeping the ventilator respiratory rate as 20, I will keep it as 40. What do you think is the advantage I'm having if I'm doing hyperventilation? What do you think is the advantage I'm having? Patient is forced to breathe in and breathe out fast. What will happen due to hyperventilation? There will be wash out of what? There will be wash out of carbon dioxide from the body. What do you call this? Yes, levels of carbon dioxide in the artery will be decreasing. Why? Because it is getting washed out through the lungs. So the level of carbon dioxide in the body will be decreasing. That's what I'm writing as decreased PaCO2. What is the advantage? See, what do you call this when so much of fast breathing occurs and the carbon dioxide is getting washed out? We call this as respiratory alkalosis. Please remember, we call this as respiratory alkalosis. And what is the advantage of this washing out of carbon dioxide? The advantage is that it will cause cerebral vasoconstriction. It is going to cause cerebral vasoconstriction. And whenever there is a vasoconstriction of the blood vessel, do you think the fluid will easily leak out of the blood vessel? See, if it is vasodilatation, fluid can easily leak out. But if it is vasoconstriction, the fluid leakage out of the blood vessel will be decreased. So decreased fluid leakage from the blood vessel will result in decreased cerebral edema, and this is going to decrease the intracranial tension. So that is how hyperventilation will help in the management of these patients. Okay, I hope you're able to follow this. Okay, that's how hyperventilation will manage. It basically cause vasoconstriction of the blood vessels and will cause decreased fluid leakage and that way decreasing the cerebral edema. That's what I'm trying to tell. Okay, then we can also give sedatives to the patient. Why sedative? Because you think about the patient. If the patient is in a coma state, it is okay. You are not able. There's no problem. But some of the patients, okay, may have confusion, and during that confusion time, they will be very agitated also. Okay, and it is found out that any agitation or any increased activity in the patient can also raise the intracranial tension. So what you can do? You can give sedatives to calm the patient. Very simple. You have to decrease the activity by calming the patient. And what sedatives can I use? What is the usual drug which we use? Something like what? Barbiturates, phenobarbital and all we use to sedate the patient. So for sedatives, it would be barbiturates. Okay, sedatives, it would be barbiturates. That's what you need to remember. For sedatives, I can use barbiturates. And finally, will be the control of seizures. Control of seizures. What is the drug of choice to control the seizure? This by itself is a repeatedly asked MCQ question. Generally, whenever a patient is there in front of you with a seizure, what is the drug you will give to control the seizure? What is the drug you will give to control the seizure? Whenever a patient is having seizure, what is the drug you give to the patient to control the seizure? Usually benzodiazepines are given in the management. Correct? Usually benzodiazepines are given. But for raised ICT associated seizure, The drug of choice is going to be phenytoin. Drug of choice is going to be phenytoin. Please keep this in mind. This is important. Okay, right? So the question would be something like this. You have a patient with a road traffic accident and having features of raised ICT. What is the drug you will give to control the seizure? It is phenytoin. Please make a note of this. This is important. Generally, the drug to control seizure is benzodiazepine, but in the setting of a trauma or raised ICT, you have increased episodes of seizure, you have to give phenytoin. That is the point which I want you to remember. Is it okay, right? So this is a special type of management which you should keep in mind. So these are all the things which you can give in the management of raised ICT. Again, quickly revising, what are the things? You can keep the patient with a head and elevation. That is called reverse Trendelenburg position. Number 2, drugs can be given, osmotic diuretic and hypotonic steroid can be given. Number 3, hyperventilation to promote carbon dioxide washout. Number 4, sedatives to keep the patient calm, barbiturates. And finally, for seizure control, you have to give phenytoin. These are the important things which are useful in the management of raised ICT. Okay, right. Okay, suppose you have a patient who's having raised ICT. Think like this. You have a patient who's having raised ICT. You are not managing that particular patient properly, or you are not taking steps to decrease the intracranial pressure in that patient. What else is going to happen? They can have raised ICT. Okay, they are already having raised ICT. What further can happen? Severe cases, they can have Cushing's triad, okay, like hypertension, bradycardia, abnormal breathing also can occur. Suppose even at this stage also, you are not decreasing the raised ICT. What is the final thing which can happen? Uncontrolled raised ICT. What final thing can happen? Something like the clues I have given in the picture. Any comments on this? Clues I have already given in the picture. Something like what? One part of the brain is moving to the other side. Something like this. Anybody wants to comment on what is this? One part of the brain is moving to the other side and all. What is this? Herniation. Very good. This is going to result in brain herniation. And this is almost like the last stage. Brain herniation is almost like the last stage. Even at this stage also, you're not taking any steps to control. This is going to result in the death of the patient. Don't forget this. This is going to result in the death of the patient. So this is almost like the last stage. Okay, almost like the last stage where patient is having severely uncontrolled ICT and can result in death also. Okay. So a few points in this brain herniation I want you to know for the exams. Some of the previous questions also are asked. I will first tell the names of this and then I will explain about only one type of herniation in detail. Okay. See, as of now, you please forget this one. Okay, you can please forget this one. What is that? Extracranial herniation. You can please forget it. That's all. Okay, other things and all, you can just quickly make a note of. Extracranial is not something common. That's why I don't want you to remember that. What is the overall most common? Number 1 is something in this area. Number 1 is something in this area. What is that? What is that? Yes. Subfalcine hernia is written. What is the meaning of subfalcine? Sub means below, right? Sub means below. Falcine refers to something like this structure. It is below this fold. Can anybody comment on this fold? Can anybody comment on this fold? Like in the frontal area, you can see that it's going in like this. Anybody comment on this fold? Any answer? Yes. Anybody comment on this fold? Okay. This fold is what we call it as a falx cerebri. This is called as a falx cerebri. Okay, it is like a layer which is separating the two frontal lobes like this. It's called as the falx cerebri. And the herniation which occurs is just below the falx cerebri. Can you see that this area is what I'm talking about? This is something below the falx cerebri. So this type of herniation, which is the overall most common type, please write it. Number 1, which is also supposed to be the overall most common type, is the subfalcine herniation. Please remember this, subfalcine herniation. Okay, subfalcine herniation. What is the meaning of subfalcine? It is below the falx cerebri. It is below the falx cerebri. That is what you need to remember. It is below the falx cerebri. Clear? Okay. And one more question I have for you is, what is the name of this area, the gyrus? This area, no? What is the name of this gyrus called as? I think all of you know. Brain is composed of the gyri and the sulci. Anybody name this particular area? Yes, very correct. What is this gyrus called? It is called as a cingulate gyrus. So it is also called as a cingulate herniation. Another name of this condition is called cingulate herniation. These are all anatomy related questions only. I'm just naming them according to the anatomical, structures. That's all. Okay. Right? It's also called cingulate herniation. This is the overall most common type of herniation where the frontal lobe is herniating below the falx cerebri. That's all. This is the overall most common type. But the point is, it is not very, very dangerous actually. This type of herniation alone is not very dangerous. That is fine. Now tell me, what is the second one? What is the second one? This is the third one also. Any idea? What is that? I have written central DTH and lateral DTH. Tell me, what is this part of the brain? What is this lobe? This part of the brain. What is this part of the brain? It's a temporal lobe, correct? It is in the temporal lobe area. Okay. Yes, comment. What is this? DTH means. DTH means D for downwards. Okay, can you see? The herniation is going down only like this. One thing, it goes in the center. That's why it's called central downward herniation. Another one, number 3, is from the side. So that's why it's called lateral and downward herniation. What is this TH? Any idea? Or you can answer, what is this structure which is separating this? What is that? This is the cerebrum or the cerebral cortex. And this one is the cerebellum. This one is the cerebellum. Anybody wants to comment on this? Something which is between cerebrum and cerebellum. Cerebrum and cerebellum. What is that? What is that? Covering, separating between the cerebrum and the cerebellum. Okay, no, not a hormone thing. I'm asking about what is the fold of that layer called as? It is called tentorium cerebelli. It is called as tentorium cerebelli. Have you heard about this? Very important name. Tentorium cerebelli. So this TH refers to transtentorial herniation, or you can just simply remember tentorial herniation. Can you see that tentorium is normally the separating area? Here it is going through the tentorium and going downwards. That is why it's called as a tentorial herniation. So number 2, I'm going to write central downward tentorial herniation. Central downward tentorial herniation. This is what is expansion for central DTH. Are you able to follow? Downward transtentorial herniation. That is what is central DTH. Number 3, what is the third one? It is lateral DTH. Lateral downward transtentorial herniation. Okay. And anybody wants to comment on one more structure? What is this part of the temporal lobe called? This part, which I'm just marking now, which is going down like this. What is this part of the temporal lobe called as? Any idea what is this part of the temporal lobe which is going down? It is actually called as it is actually called as uncus. It is actually called as the uncus. So this is also called as a uncal herniation. It is also called as uncal herniation. Just the names you have to remember, that's all. It is also called as the uncal herniation. Okay. Then the last one. What is that last one? Number 4. This is easy. What is that? I have written tonsillar hernia. I have written tonsillar hernia. Tonsil is what part? It's a part of cerebellum. So it is also called as a tonsillar herniation. Tonsillar herniation. Tonsils means I'm talking about the tonsils of the cerebellum. Please don't forget this. I'm talking about the tonsil of the cerebellum. That's what. Okay, right? So this is what you need to remember about the tonsillar herniation. Okay, right? So what I have told you is nothing very much in detail. I have just told you the names of the herniation with respect to anatomical structures. That's all. I have not told anything extra. I have just told the names with respect to anatomical structures because they have asked in your exams, which is the overall most common type, a standard question. The overall most common type is the subphalangeal herniation or the singular herniation. This is an important and usually asked exam question. Number 1. Number 2 question they have asked is, all of the following are examples of herniation encountered in raised ICT, except like that they have asked the question. Second type of question. The third type of question which they have asked in your exam is something like details of this type of herniation called uncal herniation. Some effects of uncal herniation they have asked in your exams. Okay. This is something which requires little bit of understanding, little bit of in-depth understanding. Then only you can answer this particular type of question. So I will just try to draw this little bit and then I will explain it further. See here, this is the thing which is happening. Okay, right, happening. And this is the part of the brain which is actually coming like this. What is that part which I'm trying to draw like this? This is the uncus area. That is what is the uncal herniation. Okay, it is coming like this. Now, comment on what is this area? What is this area which I'm trying to mark here? What is this area? What is that area? It is a brainstem area, correct? It is a brainstem area. What is that? Midbrain, pons, medulla, all those areas, right? And what is happening? The uncus is coming and compressing the brainstem area. Okay, any idea which part of the brainstem will be compressed? Okay, it can be anywhere, but you can just remember brainstem is getting compressed. That is the number 1 thing. Okay, and due to this brain, okay, I'll come to that point later. Okay, brainstem is getting compressed. Can any of you tell me any nerve which runs like this in this brainstem area, this area? What is that nerve which I'm trying to draw here? Can anybody comment on this nerve which is running in that area? No, I'm just asking in that area. Okay, I will give you the clue. Okay, it is more like the midbrain area. What is the nerve which is running there? What is the nerve which is running? What is the nerve which is running? Pons is little down. Midbrain, pons and medulla. Correct? I am telling you, it's the area of the midbrain. What is the nerve which is running like that in the midbrain region? It is the third cranial nerve. It is the third cranial nerve. Okay, right? It is the third cranial nerve. Correct? It is the third cranial nerve. Okay. Now, what is it going to happen? Whenever the herniation is going to occur, it will cause compression of the third cranial nerve. I hope you are able to follow this. It will cause compression of the third cranial nerve. Are you able to follow this? It will cause compression of the third cranial nerve. So now this is for you to answer. Anybody can answer this. What will be the effect if the third cranial nerve is getting compressed? First, you comment on position of the eye. First, you comment on the position. Position of the eye. First, you comment on the position of the eye. How the eye will be placed. Simple question. I think ophthalmology is over or anatomy is over. Based on that, you can answer. See, I think all of you know oculomotor nerve supplies all the extraocular muscles except two. What are the two things which are not supplied by oculomotor nerve of the third cranial nerve? You all know SO4 and LR6. I think this is what all of you must be knowing about. What is that? Superior oblique is supplied by the fourth cranial nerve. Lateral rectus is supplied by the sixth cranial nerve. So both those muscles will not be affected. Rest all extraocular muscles will be affected. So you tell me what will be the position of the eye. Lateral rectus is working because it's only supplied by the sixth cranial nerve. So what will happen? The eye will be deviated laterally. Outside it will be deviated. What is the function of the superior oblique? Superior oblique will tort the eye inwards and downwards. I'll leave it to follow. It will cause torsion of the eye inward and downwards like this. Superior oblique is also not affected. So what will happen? The eye will be torted downwards. Okay, or it will be like downwards and also looking laterally. So what do you call this? This is what we call as a typical position as the down and out eye. It is called as a down and out eye. Means eyeball is rotated downwards and also displaced laterally or sideways. Okay, that is what is called as a down and out eye. I hope all of you can remember this. This is the classical position of the eye. Second thing, I am not going to give the explanation like what I have told you now, but I am just simply asking you the question: what will be the position? What will be the size of the pupil? Anybody? What will be the size of the pupil? What will be the size of the pupil? Pupil will be dilated or compressed. Dilated or constricted. Any comments? Yes. Pupil will be dilated or it will be constricted. Very good. There will be pupillary dilatation. Why? Simple thing. Think of this as the third cranial nerve. You think like this. Think of this as the third cranial nerve. Okay, the cranial nerve is getting compressed. Think like this. This is what to say? This is the uncal area which is getting compression, which is causing compression of the third cranial nerve. Imagine like this. It is causing compression of the third cranial nerve. What is this other set of nerves which are surrounding the third cranial nerve? Any idea? What is the other set of nerves which are surrounding the third cranial area? Parasympathetic nerves will be surrounding the third cranial nerve. So what is going to happen? The parasympathetic nerves are also going to be compressed. I think all of you know what is the effect of parasympathetic on the What is the effect of parasympathetic on the eye? It will cause constriction of the pupils. When parasympathetic is going to be constricted, when the parasympathetic is going to be constricted, it's going to cause constriction of the eyes, and parasympathetic is going to be compressed. What is going to happen? Parasympathetic will not function, and so what will be the position? What will be the size of the pupil? Pupil will undergo dilatation. Are you able to understand this? It will result in pupillary dilatation. I hope you can follow this. I will repeat it one more time. Generally, parasympathetic fibers will cause constriction of the pupil, right? Here, parasympathetic fibers are compressed due to the herniation, so they are not going to cause any effect. Rather than that, it is going to cause dilatation of the pupils. That is what I'm trying to tell you. So two things are going to be happening. One is down and out eye. Next one is pupillary dilatation. All this is occurring due to constriction of the third cranial nerve. I hope you can follow this. This is number one major effect of uncal herniation. Number two, there are some arteries also which are running in this area. Okay. What is that artery? Of course, whenever we talk about brainstem and all, it is the posterior part of circulation. So there will be pressure on the which artery? Posterior cerebral artery. There will be pressure on the posterior cerebral artery. Pressure on the posterior cerebral artery. And I think all of you know posterior cerebral artery is something which supplies the visual cortex area. It is going to supply the visual cortex area. So think like what is going to happen when the visual cortex is going to be affected. Visual cortex is going to be affected. What type of manifestation they can develop? They can develop what? Both the eyes, think like this. Lateral side is getting affected, or both the eyes, medial side is getting affected. What do you call this type of vision problem? What do you call this vision problem? Very good. This type of vision problem is what we call it as hemianopia on the same side. What do you call this? Okay, homonymous hemianopia. It will not immediately cause blindness, but initially will cause partial type of blindness. That is what I'm talking about. Homonymous hemianopia. That will be the another finding related to this. Okay, homonymous hemianopia. Are you able to follow this? Okay, that will be number 2 manifestation. Third is, I told you, it is putting pressure on the brainstem. Okay, so what happened? A small part of the brainstem gets displaced sideways. Okay, and whenever the brainstem is getting displaced sideways, small perforating arteries, we call them, they become ruptured, and this can result in minute hemorrhages, small hemorrhages in the brainstem area. It can cause small hemorrhages in the brainstem area. And any name for that small hemorrhage in the brainstem area, it is called as a Durett's hemorrhage. It is also called as a Durett's hemorrhage. Okay, it is called as a Durett's hemorrhage. That's what you need to remember. It's called as a Durett's hemorrhage. And one of your exam, they asked this question. It was a little tough question, but still it's a recent question, so you have to know about it. What is the source of this Durett's hemorrhage? They asked that particular question. Any idea? What is the source of the Durett's hemorrhage? It is from the basilar artery. It is from the basilar artery. That's what you have to remember. Okay, so I know that this particular discussion may be very difficult to follow or something which is not usually in our usual learning process, but still I want you to know about this because in one of your exams they have asked specifically about what are the major effects of uncal herniation. 3 major effects they have asked in your exam. All these things should be remembered. Okay, right. So just make a note of it. I know it is a little tough at this time, but still please make a note of it. Some topics in neurology will be tougher one without any doubt, but at least try to have some basic understanding and some core, features of those particular things, which will be definitely be helping in solving the questions. Okay, right. So that's about herniation. What I was trying to tell you, when you have a patient who's having very high intracranial pressure, the patient can develop herniation, and if herniations are also not treated, definitely it is going to result in death of the patient. That is what I was talking about. Is that clear? Okay. So that's about raised ICT management and features as well as some of the complications of raised ICT I have told you. Now moving on to the next page. The next page is something like 2 conditions which are actually sort of confusing conditions. Okay, look at the names. What is that? Normal pressure hydrocephalus. One more name, pseudotumor cerebri. Okay, right? I will try to explain few things, okay, related to this because in this January exam also we had a question from the pseudotumor cerebri part. Actually, okay, there was something like a small scenario type question. Pseudotumor cerebri they have asked. I will explain that. Next, first I will explain about the other one. What is that? Normal pressure hydrocephalus. First, let me explain that. Okay, right? Okay. See, whenever we talk about hydrocephalus, what is the meaning of hydrocephalus? It's a condition of increased CSF inside the brain. Any idea when will you call it as increased CSF? Whenever the level of CSF is more than 150 ml, you will call it as hydrocephalus because normal amount of CSF is up to 150 ml. More than that is what we call, hydrocephalus. Okay, this I think all of you should have learned. I think even in your pediatric discussions, okay, they must have done a very elaborate discussion of hydrocephalus in children also, right? I think you must have heard about these numbers at that time. Okay, fine. Now, what is the meaning of normal pressure hydrocephalus? What is the pressure I'm talking about? What is the pressure I'm talking about? I'm talking about the intracranial pressure. Intracranial pressure is normal. That is what I'm trying to tell. But do you think this is not something which is fitting into our hydrocephalus part? Generally, in hydrocephalus, what are you expecting? I am expecting, in a case of hydrocephalus, intracranial pressure to be increased, correct? But here, it's a condition of hydrocephalus, but intracranial pressure is normal. That is why it is called normal pressure hydrocephalus, something which is not fitting into logical understanding, right? Actually, this condition is called normal pressure hydrocephalus, but this condition, in fact, is characterized by intermittent increase in intracranial pressure. It's a condition characterized by intermittent increase in the intracranial pressure, but not throughout. It is mostly at the night time they have increased intracranial pressure. Okay, during daytime, usually the pressure tends to be normal. That is why people call this condition as normal pressure hydrocephalus. It is more like a misnomer term only because not every time the pressure is normal. During night time it is increased. Mostly during daytime it is normal. That is why it is named as normal pressure hydrocephalus, but don't get misled by the word completely. These patients, they have raised ICP during night time. That is what I want you to remember. Now, how do you recognize the patients then? How do you recognize the patient? See, this is a condition of hydrocephalus means increased CSF. Okay, it's a condition of increased CSF. You all know that CSF. You all know that CSF is something which is produced in which part of the brain? Just a minute. CSF. I'm sorry for that. Okay, so what is the where is the CSF produced? Okay, where is the CSF produced? The CSF is produced from the lateral ventricles. Okay, CSF is produced from the lateral ventricles. Okay, right. Now, whenever the CSF amount is more, what do you think will happen to the size of the ventricle? You answer that. What will happen to the size of the ventricle? You all know that CSF produced from the lateral ventricle goes into the third ventricle and then into fourth ventricle. So when there's so much amount of CSF, logically thinking, what will happen to the size of the CSF? Very, very simple. It will result in increased size of the ventricles. It will result in increased size of the ventricles. Now, this increased size of the ventricle is going to result in pressure. It is going to result or it is going to put pressure on the surrounding structures. And that pressure is going to result in manifestations of the normal pressure hydrocephalus. So I am trying to tell that the increased size of the ventricle will compress the adjacent structures, surrounding structures, compressing the adjacent structures. And because of this compression only, because of the compression only, the features are going to be present. Okay, right? Because of the compression only, the features are going to be present. And these features are remembered like a triad. These features are remembered like a triad. Okay. Remember, I will not be able to explain all the features, but it is more or less related to the compression of the structures surrounding the ventricle. That is what you can keep in mind. One, it puts pressure on the brain structures, correct? Surrounding the ventricle, you have the brain structures like the cerebral lobes and all. And due to the pressure, sometimes the memory areas of the brain are getting affected. So this patient can have dementia, which is one of the features in the triad, dementia. Okay. Number two, instability of the gait. What do you call that? Okay. You all know that, right? Cerebellum, structures related to cerebellum are all related to maintaining the posture of the body. So when cerebellum gets compressed by this enlarged ventricles and all, what can happen? Ataxia can happen. And can anybody tell me from your anatomy classes which ventricle is closely related to cerebellum? Which ventricle is closely related to cerebellum? Anatomy classes, which ventricle is closely related to cerebellum? Any comments? Fourth ventricle is closely related to the cerebellum. So you think like this, the fourth ventricle is becoming dilated. It puts pressure on the cerebellum, thereby resulting in ataxia. I hope you can understand what I'm trying to say. Okay. Third is something related to urinary incontinence. Third is urinary incontinence. Again, here also, it is not very clearly understood, but something like the neural pathways, which are supposed to be innervating that bladder area, gets compromised due to this pressure. And that is why you get urinary incontinence. Something related to the bladder nerve supply. You think like that. Okay. That is what I'm saying. This is a little vague area. I cannot explain all the features, but please remember all these features occur together like a triad. Usually in an elderly patient, all these features are noted. So whenever a clinical scenario question comes from this particular topic, they usually start like this. This is an elderly patient who is complaining of unsteadiness of gait, forgetting things, along with urinary incontinence. What condition you will take in mind? It is normal pressure hydrocephalus. That's what you need to remember. Nobody knows the exact reason for this and all, but it is something related to high amount of CSF inside the brain. Okay. So obviously thinking when I'm going to manage this patient, what are the things which I should do in the management? I should take measures to decrease the amount of CSF. Measures to decrease the amount of CSF in the brain. So what can I do to decrease the amount of CSF? One, I can give a drug to decrease the production of CSF. Drug to decrease the production of CSF. So which drug I can give to decrease the production of CSF? Decrease the production of CSF. Any of you know any drug which can decrease the amount of CSF? Very correct. Yes, any drug which can decrease the amount of CSF inside the brain. It is one of the diuretics. It is one of the diuretics. Any idea? It is one of the diuretics. Which diuretic? It's a carbonic anhydrase inhibitor. Which one? Very good. It is acetazolamide. Acetazolamide. Okay. It will decrease the production of CSF. Okay. Acetazolamide. Second thing, what I can do is I can create something like a shunt, which will divert the CSF from the ventricle to another part of the body. Any of you know what is the common shunt which is being used for this purpose? I think even in your pediatric classes also, they must have told you about one type of shunt which can help in diversion of CSF to other parts of the body. What is that? It is something called VP shunt. Okay, it is something called VP shunt. What is that VP shunt? It is ventriculoperitoneal shunt. It is ventriculoperitoneal shunt. It is ventriculoperitoneal shunt. Okay, right? It is ventriculoperitoneal shunt. Okay, fine. Okay, so these are the measures to decrease the amount of CSF inside the brain. Okay, right? Because I feel that looking at the things which you're sending to me, right? I have already completed that like 1 minute back, and now only I'm getting all the messages. So there is definitely a good lag between what I'm speaking and when you are receiving that. So it is fine. I think till the lunch session, till the lunch break, we will continue like this only. And during the lunch break, I will ask them to synchronize it properly. Okay, because that will result in a good interaction rather than I'm getting the messages late because whatever I'm speaking is being delivered to you little late. Okay, I will make sure that it is getting corrected after the lunch. Okay, fine. So fine. So that is about this particular topic of normal pressure hydrocephalus. I hope you're able to follow this. Okay, this will be about the section of normal pressure hydrocephalus. Just keep a note of it. Slightly confusing topic, but please be sure about this. What is it? In fact, there is raised intracranial pressure only, but during the night time. The main problem here is increased amount of CSF, which is causing dilatation of the ventricles. And because of the dilatation of ventricle, they put pressure on the surrounding structures. And this pressure is the one which is creating all the problems, clinical features like dementia, ataxia, urinary incontinence, and all. It is due to pressure of that big ventricle on the surrounding structure. So, because it is an increased CSF which is causing all the problems, you should take measures to decrease the amount of CSF in the brain, which is by drugs or by creating a shunt. Is that clear? So, that is about, yes, that is about this particular topic of normal pressure hydrocephalus. Okay, fine. Then, yes. Then we are moving on to the next one. What is that? Pseudotumor cerebri. Okay, then we are moving on to pseudotumor cerebri. That was the topic which was asked in this year's January 2023 exam question. Okay, right? In January 2023, among the topics which we have discussed, itself, two questions had come. One was related to subarachnoid hemorrhage, has been asked in the exam. Another question is related to the pseudotumor cerebri. Okay, fine. So, what is the pseudotumor cerebri? First of all, it is a condition of raised ICP. Please remember, it's a condition of raised intracranial pressure. Okay. However, it is a idiopathic condition. Okay. However, it is an idiopathic condition. Why I am saying it is an idiopathic condition? Because if you do the MRI in this particular patient, it is found to be absolutely normal. Okay. That is why it's an idiopathic condition. Okay. See, you simply think like this. Okay. Whenever you have a condition of raised intracranial pressure, what will you think of? There can be something like a problem in the brain. Well, that is why the pressure is increasing. Something like a tumor inside the brain. That is why intracranial pressure is increasing. Something like bleeding inside the brain. That is why intracranial pressure is increasing. But I am saying this condition, MRI absolutely normal. That means ventricle is normal looking, brain is normal looking, everything is normal looking, but ICP is raised. That is why it's called idiopathic condition. That is the point. Okay. And also, people initially thought, okay, maybe something like a tumor. But I told you MRI is normal. That is why it's called pseudotumor cerebri. Means it is mimicking like a tumor in the form of raised ICP, but actually there is no tumor inside. So that's why it's called as a pseudotumor cerebri. There is another name for this condition also. It is called benign intracranial hypertension. It's also called benign intracranial hypertension. Benign intracranial hypertension. That's what you have to remember. It's also called benign intracranial hypertension. Not a dangerous condition. Why I'm saying simply because it's not like a tumor at all. Tumor is a dangerous thing, obviously, but it's not something which is associated with tumor. So that's why I'm calling it as benign intracranial hypertension. Okay. Now, what do you think would be the cause? I told you cause is definitely idiopathic. Nobody knows the reason. But there are some important associations for this particular condition. And this is from where the question had been asked this time. I'm putting a Q like that. This is from the association part only. They asked this question. If you know the association, okay, the first one which I used to emphasize so much in the classes had actually come in the exam. What is that? It's a young means something like less than 40 years, female, and the two obese female. Young, obese female. Exactly these type of wordings came in the exam. Okay, young, obese female patient. Okay, typically the association is with obesity. That is the point I wanted to highlight. Association is with obesity. Okay, right? Other association in a child. Any of you know some association in a child? In a child, it is excessive vitamin A, what we call it as hypervitaminosis A. Hypervitaminosis A. Excessive vitamin in a child, hypervitaminosis A. That is what is the next association. Okay. Third important association, very well possible as a future question also. I think in PG second, they are already asking the question for you also. It is expected. Drugs association. What is that? Tetracycline association. Very, very important. I'm putting a star there. It's a usual question. Till now, I don't think it has been asked for the exam, but it is important. Tetracycline association. One more thing which had been given in this particular exam also. They had mentioned obese female, and also they mentioned OCP, oral contraceptive usage. That is also found to be associated with this particular condition. So it was given like this in the question. Okay. Young female, obese female, along with OCP usage was given like that, and they asked about this particular thing. Okay, right? Okay. Right? Okay, so that is what is actually given in this particular question. So what do you think would be the features of this particular condition? I told you these patients will have raised intracranial pressure. So what do you think would be the features? Obviously, they will have all the features of raised ICP. What are they? Like headache, vomiting, papilledema, all those usual features would be present. Vomiting, headache, papilledema would be present. Is that clear, Otis? Okay, vomiting, headache, and papilledema would be present. Okay, all these features would be present. So it was given like this in this particular question. What was that? It is something like a 30-year-old female or something like that who is an obese female and who has a definite history of oral contraceptive usage, presented with headache, uncontrolled vomiting, as well as blurring of vision. However, MRI was found to be normal. What should be the probable diagnosis? That was the question in this January 2023 exam. Answer is going to be pseudotumor cerebri or benign intracranial hypertension. Okay, whatever was given, you have to choose accordingly. So, what do you think should be the treatment of this condition? Obviously, I told you it has got a very good association with obesity. So, what should be given? Weight loss should be promoted. The patient should be advised to promote weight loss because obesity is a very strong association. So, weight loss can be there. And I told you it's a idiopathic condition. So, most of the idiopathic condition, what can you advise as a treatment? I think in medicine classes, surgery classes, everywhere, whenever we have an idiopathic condition, which drug can be advised as a treatment? Yes, steroids can be useful. Here also, steroids are the drugs which are going to be useful in this patient. Nobody knows the mechanism correctly, but it is found to be helpful. Third thing, it is understood that cerebrospinal fluid, CSF, contributes to the intracranial pressure. So what you can do in this patient is that as a treatment option, periodically, not one time itself, multiple times, small amount of cerebrospinal fluid can be removed from the body. How can you do that? It is only by lumbar puncture you have to do it. Every time when you do the lumbar puncture, you let out some amount of CSF from the body or from the subarachnoid space, and that decreasing the amount of CSF itself is found to be having a good effect. Okay, so what I'm trying to say is you can do repetitive lumbar puncture, LP. That's what I'm writing, lumbar puncture. But this is like a treatment. So this is called therapeutic lumbar puncture. It's not for diagnosis at all. It's just you are letting out the fluid, small amount of fluid, so that the pressure is automatically decreasing. That is what we are trying to do. Are you able to follow this? Right? Okay. So please make a note of this. This is an idiopathic condition, something like a gray area, which we are not very sure about it. So we can try to, reverse whatever is possible. For example, obesity, you can advise the patient weight loss. Hypervitaminosis A, you don't advise any more vitamin A for the patient, and you stop giving tetracycline to this patient, advise them not to use oral contraceptive pills. All these things can be done. And along with that, the drug which can be helpful is the steroid. That's all. So please know about this topic, which is pseudotumor cerebri or benign intracranial hypertension. Are you able to follow this? Benign intracranial hypertension. Okay, right. So these are the two topics which I want you to remember: normal pressure hydrocephalus and pseudotumor cerebri. Just like a small summary of these three conditions. What are the three conditions? Hydrocephalus, normal pressure hydrocephalus, pseudotumor cerebri. For hydrocephalus, take a reference from what you have learned in your pediatric sessions. Normal pressure hydrocephalus and pseudotumor cerebri, I have discussed now. Okay, right. So what do you think will be the points of differentiation? Okay, you can tell me what will happen to CSF pressure and ventricular size in a typical case of hydrocephalus. CSF pressure will be increased and ventricular size also will be increased. This is what is the usual thing which we study in hydrocephalus, right? Hydrocephalus, more and more of CSF, so ventricular size is increased, CSF pressure is also increased. In normal pressure hydrocephalus, as the name itself says, the CSF pressure is normal. But don't forget, I told you in the night time it can actually be increased. But generally during daytime, if you check, pressure will be normal, but ventricular size is increased. In fact, I told you it is the increased ventricular size which is causing all the problems in case of normal pressure hydrocephalus. So I hope you can follow that. Okay, correct. Okay. Then pseudotumor cerebri. What is happening in pseudotumor cerebri? I told you CSF pressure is increased. In fact, all the features of pseudotumor cerebri are due to raised ICT only, like headache, vomiting, and all. But ventricular size remains normal. Do you remember? I told you. If you take the MRI also, it will be absolutely normal. So this is like a summary of differences between the three conditions, which can be sometimes confusing: hydrocephalus, normal pressure hydrocephalus, and pseudotumor cerebri. Okay, fine. Okay. So that is about the summary part, which I want you to remember for this particular section. Okay, right. So till now, what we have discussed is my primary headaches I have discussed, intracranial bleeds I have discussed, and one more thing I have discussed is raised ICP and some associated conditions. Okay, fine. So I hope you're able to understand till this point of time. I know that neurology is a little difficult. Chapter as such, but it's a very important chapter because I see every year around 5 to 7 questions being asked from this particular chapter itself. So that is why I wanted to cover a little bit in depth, and but also in a way which you can understand and can recollect in the exams. Okay, right. So we will go a little slowly only, right? So with this, I will give a lunch break now. I'm going to give the lunch break now. Time is around 1:30. By around 2:15, can we start the session? 2:15. Can we start the session? All right. Fine. Okay. So again, by 2:15, I will start the session. Just try to go through few things which we have discussed and solve some MCQs related to respiratory system with whatever guidebooks you are having. Just 5-10 minutes. Okay. Just try to refresh it. One thing I want you to, see if at all possible would be, see, because the upcoming topics would be something like neurodegenerative diseases and the chapter of stroke actually. And for the chapter of stroke and all, please try to revise from your anatomy notes. You might have studied now blood supply to the brain, different parts of the brain and all, something like motor areas of the brain and all. Because with that anatomy basis only, I can take the discussion forward. Okay, so at least you see this particular notes from your anatomy classes or keep your notes by the side. Okay, because the next topics which I'm going to discuss will have a strong correlation with anatomy. So that is why I want you to keep your anatomy notes by the side or have a look at that notes during the break time. Just a little bit. What is the main areas of the brain? What is the blood supply to the brain like that? Please have a look at it. Okay. So I will start again at 2:15. We'll have the lunch break now. Okay. Right.